go. Okay, good afternoon everybody, and welcome to the June 2022 meeting of the West Yorkshire and Harrogate Health and Care Partnership Board. Quite a lot on today's agenda, but particularly highlight partnership CEO lead report from Rob, a report on our ambition to be the first partnership of Sanctuary, update on development plans, on the people plan, particularly important report on proposals to improve discharge and flow, the latest update on tackling health inequalities for Black, Asian and minority ethnic communities and colleagues, and important, if not always exciting, the Integrated Care Board Constitution and Draft Governance Handbook. Constitutions should always be boring. If constitutional discussions are exciting, it's bad news. And we're meeting on Teams and streaming live. I know most of you are great experts at coping with online meetings for now, which means the next time I try and speak, no doubt I will forget to unmute myself. But if I could just ask people to mute the microphones when you're not presenting and speaking, but when you are presenting and speaking, please make sure your cameras are on so we can see you. We'll use either the raise hands function or the chat function to identify people who want to speak, and I'm sure if I miss anybody, somebody will let me know. So this is the last meeting of the board before the partnership before the Integrated Care Board becomes a statutory meeting, and there's quite a lot of changes. Just to mention briefly, because of that, this coincides with the end of the 3-year term for our 4 co-opted members, Jackie, Emma, Andy and Stephen. We're looking as part of the new mechanisms of citizen involvement about the best way forward with that, but I do think should take an opportunity to say thank you to Jackie, Emma, Andy and Stephen for their contributions over the last 3 years. There are various appointments I'll run through very quickly, but particularly welcome Kate Sims as Director Designate of People, not least because Kate's got an item on the agenda after about 2 days in post, I believe. Other appointments include further appointments of non-executives to the board, particularly Jane Medley, Becky Mulby and Harris Sultan, who's in the next director programme. And recruitment's currently live for 2 more non-executive directors, so check on the website. Actually, it says applications live. Actually, I think the application's closed on Sunday, so I'll backtrack quickly on that one. And a couple of congratulations to Bradford colleagues for Bradford being announced as City of Culture for 2025. Fantastic news, and we've talked in the past about the important contribution that culture can make to people's well-beings. And congratulations to Julian Hartley, who's been awarded the honour of Knight Bachelor in the Queen's Birthday Honours List for 30-year contribution to healthcare. I think I've run through all my notes. Apologies if I've missed anybody. We'll move on if that's okay. And the next item on the agenda is questions and deputations. I understand there's been one question submitted in advance from Jenny Shepherd. I think Jenny was hoping to join us to read out the question. And then yes. So if Jenny's with us, can we bring Jenny in?
Hi, Jenny. Apologies, Jenny's obviously could join the call.
I'm here.
Okay, over to you.
Thanks. Let me just find it. Okay, so thanks for the opportunity to ask this question or make this statement. It's in relation to the CEO's brief report on the role of the integrated care system in child safeguarding. So my question is about how West Yorkshire Integrated Care System and the new statutory Integrated Care Board will fulfil the board's requirement under the 22 Health and Care Act to take key responsibility for safeguarding West Yorkshire children. As I understand it, the 2022 Health and Care Act requires the statutory integrated care board to do these things. Set out the steps it will take to address the needs of children and young people under the age of 25 in its 5-year forward plans. Nominate an executive children's lead responsible for ensuring the integrated care board sets out clearly the steps it will take to address the needs of those aged 0 to 25 and for reporting annually on how well the integrated care board is delivering its duty to safeguard children. Third, consult with local leaders as they draw up their plans, closely involving children and families themselves. And finally, be lead partners in local child safeguarding arrangements, together with the police and local authorities. So, in preparing to meet these statutory requirements, does the integrated care system accept the findings and policy recommendations of the recent Liverpool and Huddersfield Universities research that was published recently in the Lancet Public Health magazine? In case people haven't come across it, this new research underscores the need for an approach to child protection that is based on the reduction of child poverty. It has found strong UK evidence that poverty increases the need for child protection. It has shown that the rise in child poverty from 2015, largely the consequence of cuts to welfare benefits, was associated with an additional 10,351 children entering care, 22,945 children being placed on a child protection plan, and 51,736 children beginning an episode of need between 2015 and 2020. These increases have disproportionately affected more deprived local authorities that are less able to manage them, and this has deepened inequalities. The research findings bear out a systematic review of the effect of household income on children's outcomes in OECD countries, which identified a causal effect of income on known risk factors for child protection interventions, including maternal mental health, parenting, and home environment. So my second question is, if the integrated care system accepts these recent research findings, how is the Integrated Care Board going to advocate for government adoption of the Liverpool and Huddersfield University Studies policy recommendations? In summary, these are, and I quote, that policymakers might begin by setting ambitious, achievable child poverty targets. Increasing the generosity of welfare to support to families with children would probably have a rapid and lasting impact. In the UK, restoring the £20 universal credit uplift, extending the same uplift to those on legacy benefits, and reversing cuts to welfare benefits, including the 2-child limit and lowered benefit cap, would lift millions of children out of poverty. These policy proposals would dovetail with the UK government's own levelling up post-pandemic recovery agenda, disproportionately benefiting the most deprived communities. Meanwhile, increasing central government funding to local authorities with funding proportional to need would support a shift away from reactive acute intervention towards preventive support. Thank you, that's it.
Thanks very much, Jenny. And certainly in terms of the recommendations summarised at the end, there's much that personally I would recognise and endorse. In terms of the ICB response, I'm just going to ask Beverly Geary, who's the Director of Nursing Designate for the ICB, if you want to give an initial response to some of those points. And welcome, Beverly.
Thank you, Chair. I'm going to respond to how we plan to safeguard children, and also I'm going to make a comment around the Liverpool and the Huddersfield findings, if that's okay. So the Health and Care Bill transfers all relevant statutory duties from CCGs to the ICBs, and the new arrangements will adhere to the NHS Safeguarding Assurance and Accountability Framework. We will continue to work together with our counterparts in the police and local authorities that form the safeguarding partnerships that exist within the ICB footprint. The place-based multi-agency safeguarding arrangements will continue, as these are best positioned to design services for and to respond to local issues within their population. System oversight will be at ICS level by the System Safeguarding Board and the System Quality Board. We do not dispute the findings from Liverpool and Huddersfield that there is a relationship between child poverty and children entering care and the disproportionate impact on areas with higher deprivation. The policy measures described are in the national government's remit. However, as leaders in the West Yorkshire Health and Care Partnership, we will continue to advocate for better funding and policy measures that reduce inequality and injustice, and we are fully committed to reducing child poverty, and this is stated in our 10 ambitions. The detail is in ambition 3. Thank you.
Thank you. Of course, we will publish a copy of that response on the website, and I'm sure it's a topic we'll return to in more detail in future meetings and future discussions. But thank you for that question, Jenny.
Is it possible for me to quickly respond to what Beverly's just said?
Very quickly. Yes.
Okay, thanks. Thanks for your response. My immediate take on it is that I asked the question in the context of Rob Webster's report on what's happening as a result of the review of child protection and child safeguarding because of the massive and horrific flaws that have led to the deaths of a child in Bradford. And it seemed to me that your response is about continuing as you go kind of thing, rather than recognizing a need for change in order for the safeguarding and child protection system to radically improve, which has been noted in 2 big recent reports, one of which is referenced in Rob Webster's response. So that's just, thanks for the opportunity to give an immediate response to what you said, and thank you.
Thanks, Jenny. Rob may well pick that up further in his report as well, I suspect. Thank you. That was the only question we had notice of today. So I'll move us on to the next item, which is just to remind members of the need to declare any interest. Of course, all the interests we have registered with our individual organisations are included on the partnership register of interest, but if there are particular items under discussion, then I'd ask people to make sure they're declared at the appropriate point. And then we have the minutes from the last meeting on the 1st of March. I'm assuming that they're a correct record, and if anybody's noted any omissions or clarity, they will flag them up to the Secretariat. But if we're happy to agree those, could I perhaps then ask Ian to take us through the action log?
Yeah, thanks, Councillor Swift. So we're on page 27, I think, of the minutes and actions, which has just got the 4 open actions. So the first one, following the conversation that we had at the last partnership board, I think it was, we agreed to bring a sustainability strategy to the next partnership board. So that will come in the September meeting. Following the quite brief conversation we had on the people plan, we said we'd do some work on the short, medium and longer term actions to deliver that plan. We'd bring that back today, and it's great that Kate Sims is with us to lead that conversation with Joe. We said we'd take a Health Watch Insight report on a 6-monthly basis to this meeting. We'll do that at the next meeting in September. And the final item is the standing item that we have on progress against the action plan on the race quality review, which is on the agenda for today. So those are the 4 open actions, Councillor Swift. Thanks.
Thanks very much, Ian. Any questions or comments on any of those? In that case, can we note that, and we'll move on to the next item, which is update from the West Yorkshire Partnership Chief Executive Designate, Rob, and hand over to Rob for that item.
Thanks, Chair, and hello, everybody. For those who don't know me, I'm Rob Webster. I'm the Chief Exec Designate for the Partnership and for the Integrated Care Board. Really pleased to be here today, and can I have my personal congratulations to Julian for the recognition in the honours list, as well as to everybody in West Yorkshire who's been recognised right across the system. Also really fantastic to see that Bradford has been awarded City of Culture for 2025. And I know that there was a huge amount of effort that went into that from colleagues right across the cultural public sector and other parts of the Bradford and West Yorkshire system. So we're all delighted, I think, at that outcome, and I'll come back to that in a moment. So people have got the report, and we produced these a week early so that people have time to digest them. So I won't go through it in detail, but I will make a few key points. We live in a context, I think, that's driven by COVID and its consequences and the health and economic recovery of the country following the pandemic. What you can see from the report is that the impact of COVID at the moment is lower than it has been because the BA2 Omicron variant wave has now subsided or is subsiding. We now have less than 80 people in West Yorkshire hospitals with COVID, around half of whom have it, although they came into hospital for something else. And numbers in intensive care have floated around 0, 1 or 2. So these are at the lowest levels they've been for, well, in terms of intensive care forever. And in terms of in hospital since last summer. So we are entering a period where the impact on the health and care system is minimised. We can't be complacent about that because we know that there are variants which will develop over time, and therefore we need to remain agile and able to respond to any increases in infection rates and their consequences, or any vaccine evading variants which may cause us some trouble. In amongst all of that, we mustn't lose sight of the impact of long COVID on individuals and people in our communities, and we continue to keep that in focus as something which we will need to continue to support people living with. Cost of living, as I've identified in the and as Jenny's asked questions about, you know, in terms of the introduction, is something which will drive ill health unless we provide some support to individuals around that. We've got a history of supporting people affected by cost of living, for example, on winter warmth payments, because, you know, the cold in the winter will drive people into hospitals and to ill health if we don't support people differently. What I've asked is that the Population Health Program take a look at all of the evidence and support that we may need to put into place if the cost of living increases are going to have a detrimental impact upon people's health and well-being, and we'll bring a report back next time in advance of the winter and any further increase in energy costs which are potentially forecast for later in this year. So that kind of combination of COVID getting better, cost of living maybe potentially causing some problems down the track is apparent to everybody. We've now moved from since the last time we met, a national 4 level incident, which is nationally managed as an emergency, to a level 3 incident, which is regionally and locally managed, which again reflects the status of COVID in the country. At this time then, we're making the most we can of improving the amount of activity we're delivering and recovering the position around performance. And performance was under great strain before the pandemic and has been put under significant additional strain during the pandemic. And we're now trying to recover as much as possible right across the system, whether that's in domiciliary care, care homes, general practice, community pharmacy, into hospitals and specialist treatments. And actually we are making good progress. We're making good progress. So the numbers of people waiting 104 weeks or more has reduced by over 90%, and we expect to get rid of anybody waiting over 2 years within the next few weeks. The number of people waiting over a year for treatment is reducing, and actually the overall number of people waiting has gone down slightly. That's a positive thing because it suggests that the capacity in the system is greater than the demand coming through at this point, which is partly what we're being asked to deliver. As we have this lull as well, what we're seeing is ambulance response times improving. So there's a national standard for category 1 calls, which is about 7 minutes. We're about 9 minutes at the moment. It's been much longer than that. For category 2 calls, again, we're closer to the standards than we have been before. So colleagues in the ambulance service have been a huge pressure and stress. Their situation's improving as sickness levels have fallen and pressure in the system has been falling, as well as the significant work we've been doing to make sure that ambulances turn around quickly at hospitals and other examples. So at the moment, the system is facing this kind of space where we want to get into recovery, and we're making some substantial progress. We're doing that in the context of signing off plans for the rest of this year against a mandate that's been issued by the government for the NHS in England, and expectations through local government channels. And those plans are due to be finally signed off by the 20th of June. Since the report was written, we've had further detail of additional resources that have been made available to the NHS, about £1.5 billion nationally, to close some of the gap between the pressures in the system financially and the income available. And just to remind people that the pressures are caused by two things. Firstly, the cost of living, the inflation impacts upon our energy supplies, our supply chain and everything else. And secondly, the COVID waves for Omicron, BA1 and BA2 were greater and longer than was expected when the settlement for the NHS was made, therefore increasing costs in the system. So thankfully, we've had some reparation for that from NHS England, and there's an expectation that we will get that resource if we're able to close the financial gap in our budgets, and if we're able to deliver on a range of programmes which nationally they'd expect us to work together on. We're already working together on some of them, such as pathology, coordinated pathology work, and the others are definitely within our purview. So our expectation is that that resource that's coming into West Yorkshire will help. And I was just going to ask Jonathan Webb to give a further update on the position as it is today on planning for the year, so that the board's got the latest position before we formally submit our final plan.
Okay, thanks, Rob. So, as you say, we've now got our determined share of that £1.5 billion additional funding that's come into systems across the country to cover off inflation and any sort of residual COVID costs. The gap that we reported, the planning gap we reported to the partnership, to the shadow board back in May was £73 million. That's the number that represents the allocation that we've now got for 22-23. So we are planning now to submit a balanced plan as a system. That doesn't come without some risk, not least the funding arrangement that's in place around delivering a national target around planned care. Notwithstanding that, the financial performance and the risks around that will be monitored on an ongoing basis from post 1st of July by the ICB's Finance, Investment and Performance Committee, as well as through place committees, as well as through individual organisations.
Thanks very much, Jonathan. So I think due to the collective actions of people across the system, we're in a position to submit a plan which we own, which is ours, which is challenging and we believe is achievable as we move into the year for the NHS. What the report sets out as well is that the planning processes that we respond to are often driven through that NHS channel, and often are themselves partial. They contain most of the work, but there are further elements of NHS planning which are slightly outside of that process around mental health and workforce and cancer. So we need to make sure that we consolidate the NHS work, and as we go forward, we need to ensure that our planning encapsulates all of our work beyond the NHS into social care, into the wider work we're doing around prevention and so on. So we have a consolidated view of our plans, particularly as we revise our strategy. So just for the board to know that. In terms of other things that we also need to keep in view, obviously we've got a session later on around the Constitution now that the Health and Care Act has passed. There were several amendments to the final bill which then passed into law. There wasn't one on the workforce, so there was a lot of cross-party support nationally and through our representative groups to have a legal requirement for there to be a national workforce plan, which set out every couple of years the requirements for the health and care system. There is work going on through Health Education England and through NHS England around what the workforce requirements might be over the next 15 years and in the shorter term for the health and care system, and we'll continue to engage with that. Last two things I wanted to say. First, sort of on a positive note, building on the work that's gone on in Bradford to secure the City of Culture, it's worth reflecting that in 2023, Leeds will have a year of culture, which is built on all of the work that went into preparing for the bid for the European Capital of Culture. In 2024, Calderdale will have Culturedale, another year of celebrating all the cultural work that goes on in Calderdale. And then in 2025, we will have the City of Culture in Bradford. We already have the Mayor putting forward 10 pledges, one of them about a new deal for the cultural sector in West Yorkshire. And we are a National Centre for Creative Health regional hub, because as the Chair has described, we know that there is a very strong relationship between culture and health and well-being. So as part of that, we need to think about how we maximise the opportunities over the next 3 or 4 years to look at prevention and the way that the cultural sector supports the economy, supports people's well-being, and is really part of what makes West Yorkshire distinctive. We're putting in a bid to the National Institute for Health Research around how we can evaluate all of the work that's going on and its impact. And we want to make sure that it continues, I think, to be a part of the agenda at this board for the future. The very last thing I'll say is just to go back to the question that Jenny asked, which is a really important question. The very short statement in my paper really is there as a place marker. The paper had to go out on the day that I think it was about the day or the day after the report came out into the tragic events in the 2 cases and the impact for safeguarding and child protection arrangements nationally. It's only right that as a system, we consider what we need to do in responding to the recommendations within that report and anything that the government chooses to take on over and above what the report suggests. And that's where the Quality Committee can look at the detail and make recommendations to the ICB and to this partnership. All of the work that's going on in Bradford, and I commend the work that my colleagues are doing in the city around improving the position there, all of the work we're doing in other parts of West Yorkshire around children's services is also, relevant here. And the fact that children and young people are a priority for this partnership shows that integration isn't just about adults and older people, it is about children, young people and families too. So I think that our work in this space will continue to be a priority, and it indicates something which I've said before at the shadow board of the ICB and here, that we've got to have a focus on safety, and we've got to consider that first always, so that we ensure that people are always safe in our services. That's all I wanted to say by way of reflections, Chair. Happy to take any questions or comments.
Thanks very much, Rob. So can I see if there are any questions or comments for Rob on issues raised in the report? I'm not seeing any at the moment, Rob. So I'll kick one off. I didn't know if you made mention in the written report to the I could say the Fuller report. It isn't called the Fuller report, is it? And obviously that raises quite a lot of work. I just wanted to say a bit more about sort of what the next steps for the partnership in terms of where we discuss that will be.
Yeah, thanks, Chair. So Claire Fuller, who's a GP in the south of England, and also an ICB Chair, Chief Exec Designate, was asked by NHS England to do a report, a stock take into the state of primary care general practice and wider community services. And it was a good process which engaged all 42 leaders and asked for evidence from across the whole of the system and the whole of the country, including from families, carers, patients and citizens. And the report comes up with a set of recommendations for ICSs and a set of recommendations for NHS England and the government. And the recommendations for us really fit with our core purpose, I think, around joining up care. What they say is ICSs are best placed to develop multidisciplinary teams in neighbourhoods which meet the needs of those people in those neighbourhoods and are sensitive to the different makeup of people in those neighbourhoods. As we know, our 52 different neighbourhoods in West Yorkshire are all different. So ICS is in a move away from, I think, a sort of top-down, centrally prescribed approach. There's a suggestion that ICSs need to develop with general practice, community pharmacy, community dentistry, community services, social care, joined up services around the needs of people in those neighbourhoods. To do that, we need to be able to move on with our work, some of which we're talking about later on this agenda around flow, some of which is a legacy of the work we did on vanguards or integration pioneers. But it really is all about what goes on in communities and how we stop the burden of treatment on people having to repeat their stories over and over again to different agencies. So at its heart, something very simple. It also says that general practice and people accessing that need to, there's three kind of categories of people or needs. You might need some needs today because you want something sorting out. You might need ongoing care and support in a partnership with your practice and the team, or the team could be supporting your well-being through prevention. So trying to make more of an emphasis on ensuring that people can get fast access if that's all they need, people can have good ongoing relationships if that's what they want, and that there is a role in prevention for primary community services. From the government and from NHS England, what the Fuller report's asking is for a greater focus on the estate in primary care, a greater focus on the workforce in primary care. So, for example, there is no staff survey for staff in general practice and primary care, so we don't know how they feel in the same way as we would for people working in hospitals or mental health services. So, big focus on the workforce, and then a focus on data and information, how it travels around the system to make sure that that can be shared to coordinate people's work. What we need to do is see what the government response is and really just get on with our elements of that work and keep lobbying for the implementation of the recommendations through NHSE and DHSC, I think.
Thanks, Rob. Okay, so I'm not seeing anybody else want to come in on that. So can we note the various points in Rob's report and move on? Thank you. Thanks very much. So the next item is our patient and public voice item, and I'm going to ask Em Irving to introduce this.
Thanks, Councillor Swift. So yeah, I'd just like to introduce a video that's been produced by the Leeds and Gypsy Traveller Exchange. They've been working with gypsies and travelling communities and health professionals to look at, they've produced a pack, a staff resource, and the video is them talking about their experiences of health and care systems. This work was undertaken as a result of a request that was put into the Health and Equalities Academy to develop training resources for staff to support and improve outcomes for our population facing the highest inequalities. And as we know, through working with Leedsgate and other partners across West Yorkshire, there's a stark gap in life expectancy between the gypsy and traveller population of around age 50 compared to age 79 in the general population. We also know that gypsies and travellers report the poorest health outcomes of any ethnic minority and that they're less likely to engage with services. So this video really is just giving you an overview in their voices around how it feels to be a gypsy, a part of the population of gypsies and travellers in West Yorkshire, and their experience of healthcare services. So long as my screen sharing works correctly, then hopefully you'll all be able to see and hear. Please let me know if you can't.
There are approximately 7,000 gypsies and travellers living across West Yorkshire, and we have 5 sites that are provided by local authority. We then have a number of people that are living on the roadside, and that fluctuates, but approximately 80 families. And then we also have a number of people that live on what we call yards, and then we also have a significant number of people in housing as well, be that owned housing, private rented or socially rented housing. And in fact, about 2/3 of gypsies and travellers do actually live in bricks and mortar housing.
People within the gypsy and traveller community are no different to anybody else in terms of that health is really important to them. You know, they want to access health and social care systems the same as everybody else does. I suppose after years of experiencing really quite poor care and access, then it can lead people to feeling a level of apathy that, you know, it's really difficult to access, so why should we?
There was a study in 2004 in Leeds which described the life expectancy as being 50 for gypsies and travellers in Leeds. That was a 28-year gap from the rest of the population. So, you know, we do have a crisis, a health crisis for gypsies and travellers, and it's not being addressed appropriately.
I always lived at Leeds site, but about 4.5 years ago I moved to London, but it was only temporary, a couple of months, and I was having a baby. So I got a temporary doctor up there to get seen to because I was having a lot of problems. So then it was time to move back down home. So when I moved back down home, I tried to get back in my own doctors. So I said, I need to book an appointment, I said, with a midwife. So they said, you're off the system. So I said, well, why am I off the system? I said, I've always been here. I said, I moved to London, I said, for a couple of months. I said, but it was only temporary. So they said, no, you can't register back in because your address is too far. So I said, how is my address too far? I said, when I've already been here, I said, since being small, and I said, and my mum's there. I said, my brothers and sisters is there. I said, what's the problem? They said, no, we're not allowed to have you back in. I felt very worried because I couldn't drive, so I had to get taxis. I never had a phone, never had social media. So I thought, how else am I going to find doctors? I wanted that receptionist to listen to me more and understand my situation. She could have said, right, fair enough, I can't book you in, but look, I'm here to try and help you. Let me see what I can do. Like, talk to me nicely. I would have been happy with that, but she just wouldn't listen. She was just rude. She wasn't having any of it.
You know, this is somebody who's having a baby. They should be prioritised for, you know, for that medical treatment and to sort of being able to engage with services, and to be turned away from a practice that you previously were registered with for the same address that you were registered with before is ridiculous, and it really does show that real inflexibility within systems.
I got in contact with Leedsgate and we found Liz. She's an outreach nurse, and she was the one who helped me get a doctor. And they booked me in straight away. They said, you need to get seen straight away. So if it wasn't for Liz, I don't know what I would have done.
Stories are powerful and stories are true, right? And we should be able to listen to experiences and change things on the basis of those stories as much as on the basis of data. So I think people that are sort of responsible for, commissioning or managing services should be thinking about how do we connect to communities, not just gypsies and travellers, lots of different communities, to understand what's really going on for them, what really is behind, you know, these numbers or these lack of numbers, what's happening for people on the ground.
I think starting with yourself, that's your main tool as a practitioner. It's yourself, it's what you bring to the table, and really considering what your bias is and where you're getting your information from. We need to really know our population as nurses and know who we're working with, and there's something about noticing who's missing. So I think everybody's really busy with the people that engage with us, that services don't often think who's not here, who are we not seeing. the responsibility is back on the practitioner, not on the community. So I think it's looking at it from that systems level, and then more strategically thinking, what do our services look like for this community and other people that are experiencing health inequalities? What does it look like through that lens, and really sort of like breaking it down to what the barriers are, and then being accountable for what those barriers are, and working forward from there.
I think that health systems should be reaching out to people in the voluntary sector that are doing this kind of work. Find out where your local organisation is, reach out, try and build those relationships, build up trust. A lot of gypsies and travellers live roadside and don't have access to doctors. You should be there to support them and help them get access to our doctors. Just listen to the stories, listen to my stories and help them.
Thanks very much, Em. Is there anything you want to add to that video at this point?
I think it says it all, really. There's lots of work ongoing within the Improving Population Health Programme. We've got the Core 20 + 5 connectors that's going to do some more work with the gypsy and traveller population. And obviously, that population and others will be picked up in the Inclusion Health Unit that we're going to be establishing over the coming months. So, yeah, that's all, really.
Thank you. I agree. It's a very powerful video. Thank you for sharing that with us. Can I bring in Councillor Venner, Fiona?
Thank you. Yeah, I just wanted to share something we're doing in Leeds. So our Health and Wellbeing Board has got a programme called the Lship Program. And every single member of the board, which obviously is very senior people in Leeds like Julian and Thea and Sarah, some of whom I think are on this call. So it's like the chief execs of all our trusts, the most senior leaders within health and care in Leeds are all paired with a third sector or community-based grassroots organisation to work with them specifically on health inequalities. I'm actually paired with GATE, so I'm working with GATE a lot at the moment around the gypsy and traveller community, and I chair the Leeds at the council's working group on gypsies and travellers, and we're working on various things, including the need for more pictures and negotiated stopping sites, but also mental health and suicide in the community, and children's access to education. But the Lship program is amazing. It's really powerful in terms of linking people who are senior enough to be able to change things with people working absolutely on the front line of health inequalities. So if anyone in another area wanted to look at doing something like that, we'd be really happy to support that in Leeds, because I think all of us involved in it, both the health and wellbeing members and the community organisations, are getting a huge amount out of it. And the reality is, the sad reality at the moment is, in terms of the community I'm supporting, people who are from the gypsy and traveller community generally don't, at the moment anyway, get into positions of power and influence. So we're really reliant on people like us to be advocates and to be allies. So I think it's a responsibility we all have, really, to support the development of leadership in communities that are marginalised, and to work alongside people as allies, because the communities we're working with through the Lship programme are the communities that are facing the worst health inequalities. As you heard in the clip, the gypsy and traveller community has Victorian levels of life expectancy. So yeah, really happy to help if anyone else wants to do something similar in your area. Thank you. Thanks,
Fiona. That's really interesting. And yeah, if we could make a reference to that in the minutes or actions of the meeting, so people can pick up and follow that up with you, that'd be fantastic. Rob, do you want to come in on that?
Yeah, just to quickly follow up on that, I think it's so thanks for everyone who's been involved in making the film, and thanks to Gate, who I think do fantastic work. I think generally this shows the power of the partnership, you know, ensuring that you've got trusted voluntary sector organisations working with communities who sometimes found it very difficult to access services or influence them. So the fact that we've got a partnership which is made up of the council, the NHS, third sector organisations and communities gives us an opportunity to put that right. So I think the film, it helps to demonstrate that that's where we need to be continuing to go as we become an integrated care board within an integrated care system. I think on the specifics, I thank you, Councillor Venner, for the offer, and I think we should pick that up as part of the OD programme. We've got place development programmes for each of our 5 places, and I think this is exactly the kind of good practice that should be shared through the OD work, and I can see Kate nodding and can pick that up as an action if people are happy with that. And I think we should also keep this community of gypsies and travellers in mind when we're having our conversation later about the update on Black, Asian and minority ethnic communities and their experiences of services and of our staff, because it may not be the community we're always thinking of when we're going through those conversations, but it's definitely part of the conversation we should be having.
Thanks, Rob. Notice a number of kinds of agreement with that message. Okay, I'll take us on then to the next item, which is about the work on becoming a partnership of sanctuary. And can I ask Robin and Em, I think, to, introducing this item? So over to you.
Yeah, thank you, Chair. I think Em's going to put some slides up that you should have already seen that we'll go through quite quickly. Just while we're doing that, can I just sort of note that was really helpful discussion and the offer from Councillor Venner. We actually had a conversation with Cabinet in Calderdale yesterday about this issue and the excellent work that Leeds is doing, and I think somewhat ahead of us in Calderdale. So we are really keen through our Director of Public Health to build on that and work with you on that, because the disparities are absolutely shocking and greater than anyone would expect in terms of the life expectancy and well-being of the gypsy and traveller community. And just also, while we're setting up, just to say that I really commend, I've to add to what Rob has said earlier, I really commend the question from Jenny Shepherd earlier on, and to say it's absolutely a kind of touch point issue, I think, for the integrated care system and the board and local authorities, and certainly up there at the right at the top of worries and concerns that local authority chief execs have about the state of the children's social care system. I would say that this isn't, I mean, there's been a focus on one place in Bradford because of the report, but it's something we all feel and all worry about. And I would say the Josh McAllister report, if you get a chance to look at it, is outstanding. It's not often you read about love being the fundamental essence of what we need to do as a system and provide our children, young people in a government report. So it's very powerful, and I hope the government does pick it up and follow it through, because it does say very starkly that the system is seriously at breaking point, and it's probably got 2 or 3 years before it collapses. So something has to be done about the state of children's social care with those with complex needs, particularly out of borough support, and that's true for everyone in all local authorities and health systems. So I think it's really good to have that question. So this is a presentation about the Partnership of Sanctuary and just excellent work that the team are doing, improving population health program, and I think we came to you late last year with a proposition to progress this work and to become, I think, probably the first integrated care board that will be a Partnership of Sanctuary. Since that time, we have now the added dimension of the response to the tragic events in Ukraine and the kindness and resilience of our communities coming forward for that programme, building on the significant issues around Afghan resettlement, and also often less spoken about, but the continued issues around those seeking asylum from all over the world, and some of the kind of contentious issues around that, but also the reality that people are presenting in high numbers. So if we move on just to the what we're trying to achieve, and essentially we want to share good practice, we want to learn and embed. great work. We have some really excellent partnerships with Bevan Healthcare, led in Bradford, but also in other parts of West Yorkshire. But we recognise that, again, we are dealing with individuals and families that are often in a state of both emotional trauma, have physical needs and support, and also maybe beyond what is anticipated or expected. And that's just as an aside, one of the things that's less sort of discussed, but the Ukrainian sponsorship scheme has been brilliant about people coming forward, but it has been challenging in terms of just the impact for the individuals arriving in terms of the support they need. Okay, move on. So this is not new. This is building on the work around health inequalities to long-standing multi-generational communities within West Yorkshire, of our Black, Asian, minority ethnic communities, and also those that are newly arrived from around the world for all sorts of reasons. So that's we're applying the principles we always apply, and we work from place and we work at scale when it adds value, and when some of the specialist support or evidence or best value would support that to progress in that way. We've got a community of practice and some great learning already in place, and the Academy has got another event later this month, and do look at that. There's some great speakers to build on the learning around health inequalities. Okay, next slide. So this is some of the resource, Solace, who do this in this context, the Migration Refugee Organisation, not the organisation supporting local authority chief execs, so the West Yorkshire organisation, and the Doctors of the World. So there's some support for primary care networks in dealing with these issues, and dealing with, I know, in all our places, two particular issues. One is that people are staying in hotels for many, many months, and that can be really challenging. And also unaccompanied children who maybe aren't even arriving through unofficial means. So at 4 o'clock, I've got to go to a meeting with the Minister, a national meeting about the fact that we are seeing increasing numbers of children, young people from Ukraine arriving in the UK, even if that isn't actually what the Ukrainian state wants to happen, or necessarily that we are set up for. So these issues are emerging for children and adults around migration and asylum. Okay, yeah, next one. This links into the Core 20 Plus, the Equity Fellows, the work around adversity and trauma, and the fellowships that we've got to support colleagues within the workforce to support skilled an excellent practice led also by Health Security Agency at OHID as well, and Kathy Railton, who does a great job to represent these issues at a national level for the whole Yorkshire and Humber region. Yeah, okay. So what we're asking for you today is just to support the ongoing journey around accreditation of part of the Partnership of Sanctuary. In the report, you'll see that each place has either been formally either a city of sanctuary, or in our case, a valley of sanctuary in Calderdale, and that gives a range of support. It gives a bit of a standard, I guess, around some minimum standards, and around population health and individual support. Supports our voluntary and community sector that play a pivotal part in this, and we're just asking you to support this sort of route the next few years. I mean, maybe share any immediate issues or concerns as we move it forward. Okay, is that? Yep, is that the last one? Yep. So Emma, I don't know if there's anything you want to add to that before we just open it out.
I think just to add that we've actually got the panel meeting for status on the 30th of June. We don't envisage there being any problems. There's lots of work been undertaken around the action plan and what we have to prove and evidence that we've done in advance. So we've been given quite good assurance that we'll get through the panel, and hopefully by the end of the month we'll have the status. And that's when the hard work begins.
And in terms of the so what question, I guess, in terms of the difference it will make, it gives us the kind of standard, it gives us a sort of benchmark, doesn't it? Is there anything else you'd add?
No, I think to get the status as one of the first ICSs, and I know Solace are very much working on how they can support other ICSs across the country to get this status, but it really does show that, you know, we want to make a difference. I think somebody popped it in the chat earlier about allies, and what Marvina said around, you know, show, act, listen and yield, and I think that's what the ICS of Sanctuary will allow us to do.
Thank you. Okay, Chair, I think that's our bit. We can probably take the presentation down now, and thank you.
Oh, I thought I had, sorry.
That's great, thank you. Okay, questions or comments? And yes, Viv.
Thank you, Tim. I mean, it's a really interesting report and some real advances, and I fully support it. I suppose for me, it's about how things going forward address issues such as if an asylum seeker is initially refused a first application, they have no access to secondary care then, and it's left to primary care to try and maintain, look after. You know, if we're talking about getting rid of inequalities, I don't know what can be done in this, but it is something we should really keep focused in mind, that it isn't everything sorted, because, you know, while legislation does that, it creates an inequality for these people.
Thanks, Viv. Yeah. Fatima, can I come to you next?
Thank you, Chair. Hi, Robin. I'm just responding on behalf of the Race Equality Network, and understandably and unsurprisingly, they're overwhelmingly behind this. I suppose the only query was, how do we ensure that this is being equitably presented and experienced by people living in the grassroots of West Yorkshire? Because we're very good at sort of amplifying things at a system level, but the real test will be how it feels for people on the ground. And I suppose the other question is sort of, what support can the network offer as well to make this a success, because we're really committed to supporting this piece of work.
Thanks. Robin, do you want to come back on those?
Yeah, I mean, I think hopefully it's a really good point, Fatima. I think we would want to amplify it through the place sanctuary status that each of us has. So, and that we would want to build connections where it's valuable to do so. So I don't think it's about taking away from that. So I think it does give that access to that, and also in the individual place networks as well. And now we're looking at how they relate to the overall West Yorkshire network. I do think there is something about recognising, and again, there's a bit of a crossover to different programmes here, but I know the harnessing the power of communities work is working a lot with the voluntary community sector. Just to say that we are working a lot with the voluntary community sector around this, and recognising that, and through the review, Dame Donna Kinnear review, there was recognising there wasn't equity around some of the service quality and service breadth in different places. So I think there's been some quite dedicated work with that Em and the team are trying to address. So it's picking up some of the gaps and some of the differences in experience around different places, but recognising that we are a mix of urban and rural communities as well. That for some extent, that some communities are now only experiencing dispersal, or people from those seeking refugee asylum status for the first time. So I think hopefully we're doing it. I mean, you could say if we're not, hopefully doing it, but there's places like Bradford that have been doing this for 20, 30 years. There are others that are much newer to this. And I do think the community of practice is really the method that we're trying to do to make sure there's a level of skill and knowledge, because there are some simple things around when people arrive, access to primary care, language, or how things are expressed. I mean, there's been issues about just the first contact, the first information sent, some much better than others. So we are trying to give a sort of common standard and working with the local partners and the networks on that.
I think as well, Robin, and one of the things we've talked to the City of Sanctuary about around the status is this is about how we connect as a system. So it's not doing for the places of sanctuary. It's about how do we connect what they're doing back into system level provision and the health provision. And language is so important, and how we can make that consistent. For example, a meeting I was in around the Ukrainian refugees was, can we do a quick and dirty assessment at the airport? And it's like, no, that's not the language. So having an ICSO sanctuary and being able to have that consistency and feel comfortable to challenge instances like that, I think is one of the things it will bring. And how you can get involved, Fatima, as I said, getting the status is one thing. The hard work is keeping it for the next 3 years. And that's where we have to really, really action what we've said we're going to do. So Paula Sheriff, who's leading on this for our team, will be coming round all of the programmes, and we'll make sure we come to the Alliance as well to say, what's your gift, what's within your gift to contribute to this, and how can we work through your systems to be able to do that. And that's really important if we're going to succeed and keep the status for the next 3 years.
Thank you. Okay, I've got Rob next.
Yeah, thanks. This is really good to see, and good to see the discrete actions that are set out in the annex. And I think the suggestion I was going to make was that if you look at the sort of areas of work that we're expected to deliver on, and then the specific actions, it picks up some of the comments made by Councillor Kendrick, for example, and also adds some things which are relevant to other programmes. Thinking of things like the contribution of vulnerable migrants, refugees and asylum seekers to the NHS. We've got examples of people coming to work in the health and care system, for example, that needs to be picked up by the People Programme. So my suggestion would be that we get an update to the Integrated Care Board in about 6 months' time on what the action plan looks like, where the risks are, and if there's any barriers that need to be overcome, and that the Partnership Board receives an update next year, kind of 1 year on, to say, look, this is the difference that we've made by taking this approach. Because I think coming back to this would be something, just as with the race equality review, that we need to keep on the agenda.
Thanks, Rob. That's a good way forward. And come to Brodie next.
Just a quick couple of comments, really, and I think it's brilliant work, and I share some of Fatima's contribution to the conversation. I wonder how much of the role and remit is about direct support for migrants in this country, and how much of it is about the hearts and minds of the communities. The latter just seems so important in terms of making progress, and without that in play and active, then the former is really got a tough journey. The second point was something about connection with statutory bodies. Are you linked in? This is a contentious area, let's be clear. And I wonder how much you're connected in with Home Office government related arrangements, because there are people from the Home Office in Leeds who operate around the question of migration. So I was perhaps curious, but there might be some value in that sort of connection, which can give a much more constructive message out to communities than if you leave communities guessing about it.
Thanks, Brodie.
Yeah.
Robin, do you want to come
Yeah,
back?
I just to reassure you, it's in another hat, but I have a lot of contact with the Home Office, and also Migration Yorkshire that we have, that is our regional or strategic migration partnership links with them. That's what I've got another meeting today on. So I'm the lead chief exec for Yorkshire and Humber region on asylum, and that involves continuous conversations about migration with senior civil servants and the Director General. So we are very connected. To be fair to the Home Office, although this is obviously a very politically contentious and sensitive issue, they invest a lot of time and energy in engagement with local authorities and the voluntary sector in how this is managed, and we have a very established model for doing that. But having said that, this remains challenging, and your first point is really important as well about the differential experience, and that is what we're seeing. And a lot of it is not just because some communities are less used to newly arrived communities and refugees and those seeking asylum, but also it is quite hard if the infrastructure isn't there. You know, if the transport isn't able to access you to services, if the services aren't actually located in a way that's convenient. I know that there's I was at St Augustine's, which is our absolutely outstanding, amazing local voluntary sector lead organisation in Halifax, and there's a young man who's currently in a hotel in a leafy part of Calderdale who walks 6.5 miles every morning to go into, who walks, you know, into St Augustine's, where he spends his day, and that's the reality. Living on less than £40 a week while he's waiting his, you know, the outcome of his application. So there is all sorts of challenges, but we are well connected into that, and some of this work is actually aiming to improve practice everywhere, regardless of where you're dispersed to, regardless of if you're in a hotel or if you're in more settled accommodation.
Thank you everyone for those contributions. So I'm I take it that we're happy to note the report and the actions being taken, and to take on board Rob's suggestion about how we check up on progress as a system going forward. Thank you, everybody. So that brings us on to the next item, which is delivering the West Yorkshire People Plan. So this is progress on actions to deliver the plan which we adopted back in March. And can I invite Kate Sims, Joe Farn and Jonathan Brown to introduce this, and welcome again, Kate.
Thank you, Councillor Swift. And just to say, we'll undertake a short presentation with my colleagues who hopefully most of you know, Joe Farn, Associate Director of System and Leadership, and Jonathan Brown as the Interim Associate Director for Workforce Planning. So it's a bit of a joint effort because, as you rightly said, I've not been here long enough to take too much credit for the work to date. So, but I'll start us off. Hopefully people have had a chance to read the paper. As you've mentioned previously, following the approval of the People Plan back in December, today is really an opportunity to provide further update on the progress that's been made so far. I know there was a very short reference in March, so today hopefully a bit more detail will suffice. I obviously arrived only last week, and I have been struck myself by the work that's already underway around the people agenda. It's a huge agenda, but there's plenty of good work right across the system. And I wanted to pause and thank, certainly there's many people who are involved, but clearly from closer to home for me, obviously Brendan, who has chaired the People Board, thank you for all your help, but also Sarah Brewer, who's no longer in the Directorate, and Joe, recognise that the work that's happened to date. As Rob has said in his chief executive report, I think a priority for me is to now really take some of these work streams forward and bring them to life. And I think a key priority for myself personally will be to continuously review the priorities. I think that the people agenda is very broad, and it'd be really important to make sure we are focused on the right priorities. I would propose, because it is a big programme of work, that for future updates we probably would bring a theme, one of the pillars that we refer to in the paper, and we could do perhaps more of a deep dive to provide a progress report. So that's something perhaps we can debate at the end. So just this short presentation from us all. As I said, the context is to provide an update following the approval back in December. I think for me, a key question is how priorities have been formed so far. And I'm really pleased to see the engagement work that's taken place right across a number of workforce committees, but right across all the places. And we'll touch on those briefly in a moment. I think a key balance is identifying the priorities against new and emerging issues and being able to be agile, as that slide suggests. New and changing priorities come in, an example of that being the vaccine workforce and how we are ready to respond to that as a system. And it will be always important for us to ensure that the People Plan is aligned to the operating plan and, of course, the current one of 22-23. I think it's an important point to pause to say we also recognise we need to ensure that the current People Plan is aligned to all the opportunities within the social care workforce strategy, and really also to recognise where further development might be needed in areas such as digital and the voluntary sector, and to make sure that we're adding value in terms of being able to support those plans. Thank you, Jonathan. I felt it was an important start for me to just reference some of the people priorities. I think we clearly recognise there are a significant number, and I think the key thing is to ensure that people, whilst they're doing marvellous jobs of work, do feel valued in doing so. Some of the points I've raised here are perhaps obvious, but I've been really struck by the repeated themes only in my last few days of induction meetings. I think the health and well-being of our workforce is absolutely critical. And I think certainly for me, I would hope that that would always retain as one of our big priorities. And I think it's a key aspect of the retention of our workforce moving forward. I'm aware of the fact that this very week we have Carers Week, and some of the initiatives about supporting both managers and making sure that they know how to support carers, working carers within their departments and directorates, but also how we support younger carers, etc. And I think these are key aspects which we will want to keep checking in on. I'm really delighted that we have an ambitious plan around the equality, diversity and inclusion agenda. And for me, I think it will be understanding how that narrates from a workforce point of view, and importantly, how that impacts on wider health inequalities. And I'm really checking in on how that contributes. I think a key aspect has to be about meeting operational priorities. We need to ensure that we are able to recruit to the vacancies right across the system, but also there's a really important point around having that future planning model in place. We've got to be able to identify really clearly what our skill set requirements are. And I think, as I say in this slide, about making sure that the work with the Workforce Observatory is a key priority, particularly I think for me and the team over the coming 12 months. And I guess a part that really also excites me is around the contribution that we can make as a system to the wider aspects of West Yorkshire, including economic growth. So I just wanted to capture what I felt were some of the key priorities, but also I think what's really coming through in the messages to me over the last few days. Jonathan will now take over, but one of the next things we felt is we recognise that there's plenty more to do from obviously recruitment to vacancies, but it's also important to reflect that there has been growth in the system. So I'll now hand over to Jonathan for the next part. Thank you.
Thank you, Kate. Thank you, Chair. So I'd just like to introduce some of the successes in terms of growth since March 2019, really, a remarkably difficult time for the NHS and health and care workforce right across the whole system in all places, and we have seen an expansion. So we've seen across the NHS secondary care sector 11% in total. Excuse the acronym NEY, that's North Eastern Yorkshire. So we're a little bit above the average for North Eastern Yorkshire, but in general practice a little bit below the average, which is 7% across North Eastern Yorkshire, but 5% in general practice terms. In secondary care, the 11% growth includes an increase, of in medical and dental of 17%. In numeric terms, that's 843 doctors, and support to clinical at plus 14% is 1,755 people in employment that weren't before. So really good growth really over a difficult period. There is a small decrease in GPs, accounting for that 5%, but we are seeing more GPs in training coming through, and perhaps something that we will need to focus on is that decrease in nursing. But we're aware that there are new roles in the system, new roles in general practice, and transformation of workforce activity going on that really makes a difference there. Social care data, we are working really hard to plan together, work together with our colleagues in Skills for Care. And as you can see, again, there's a circa 2,000 rise in people working in local authority and in the independent sector. So, vacancy rates at 4.6%, not, is a relatively good place to be on the surface, but we have a lot of work to do to understand that better. In terms of our operating plans, that's the plans that the system is putting in place for this coming year. Demands for growth there are at circa 4.5%, which is another 2,650 people, and that is challenging, and we will be focusing on that as a priority, as Kate said in the previous slide. There has been extensive engagement in creation of the people plan and the delivery objectives within it. Kate mentioned in her opening line the work that Sarah and Joe's undertaken under the leadership of the People Board and Brendan. And there has been extensive work across all the health and care and voluntary sector over the past 2 years, really, to get to the place where the plan is now. And that culminates in cross-place priority workshops to refine the objectives that remain in the plan, and the next one being in June of this month. So you can see March 22, then June 22. It's a regular review process, and the sharing of current priorities and progress against areas of work is picked up in those cross-place workshops. In terms of workforce planning, we do want to improve in this area, and we have set up the start of that journey with some workshops in June. These workshops, there'll be 4 of them. They're place-based, so there'll be one in Bradford, one in Wakefield, one in Leeds, and a shared one between Calderdale and Kirklees. They will start a conversation about system-wide planning. And this is modelling across a system rather than by organisation. So we truly understand where the priorities are for investment. And that investment is so precious. Getting the right people in the right places is so important to us that we think those conversations must be system-wide and across health and care and the voluntary sector. So we'll be starting that in June. It is a start. It's quite ambitious, but we hope it'll take us to good places. We will also work with those systems on the best way to do that. Just a quick overview, really, just to show you that there is a cycle. there's a cycle to workforce planning, to workforce investment, to priority setting, and the refresh of the strategy, the annual processes that we're engaged in, just to is underpinned by a process, and of course that takes into account local priorities and also national policy and any legislative changes that we need to cope with. I'm going to hand over to Joe now, who's going to go through some of the people plan work streams for us. Thanks, Joe.
Thanks, Jonathan. Hi, everyone. Since March, we had our little a brief discussion, didn't we, in March about the delivery plan. Since then, myself and team colleagues have been doing a lot of work on defining what are the work streams that will enable us to deliver our 5 people plan pillars and our ambitions for our, as Kate said, really wide, broad ranging people agenda. What I won't do is kind of labour the list of things. You've got the list in your annex of your papers. It's to give you some assurance that we are going into the next level of detail on how we're going to deliver the people plan. We've aligned it to the 5 pillars, so you'll recognise those. Jonathan, you could probably skip to the next slide just linger on it for a little while and then skip to the next one. Those of you that are keen-eyed will note that some of those work streams actually contribute to more than one pillar, as you would hope. And we've identified some themes that we consider to be golden threads that enable, many of those people plan priorities, retention and health and well-being being one example of that. So we've been working on the detail of the work streams, the timescales, how we measure that progress, and also how we govern the progress as well. So Jonathan, if you want to skip to the next slide, please. Thank you. This slide just highlights some of that detail that we've been doing on the metrics, which are really important, aren't they, to enable us to determine if any of the changes that we're making are leading to the improvement that we seek. We've got a situation where some of those metrics already exist, and there's an example of one of the work streams there in the table where we've got some good metrics available to us already in the form of the Workforce Race Equality Standard. For some of our work streams, though, we're having to work through them in a bit more detail with the support of our business intelligence colleagues to look at how we would measure the impact of them, what data we've got available, and how we might capture and collate those, because they're not totally readily available to us. So we're still working through that, and we hope to make progress on that in the next period. This next slide, thank you, Jonathan, just describes the governance world from a people angle. So what we've done is pulled out what we've got as an integrated care system, and you can see some of those system-wide fora that are clearly interested in the people agenda. We've got our direct governance route into the people board, and that currently exists, which will go to what will become the integrated care board from certainly the 1st of July. We will also maintain a reporting route into partnership board, as we've expressed earlier, and other partnership-wide fora. At the foundation of this is our pick places, our place people committees, or equivalent ways of describing them. The other ICS programmes, that most of which have got a workforce focus, and also the provider collaboratives. We see ourselves as an enabling function to all of this, rather than kind of core to it. So we're reflected on the right hand side, and obviously a very clear relationship with our NHS England colleagues as well. Next slide, please, Jonathan. So just to briefly summarise where we're going next with this, and I think Kate said some of this and Jonathan has, so I won't repeat too much of it, but it's a continued dialogue and continued engagement with and across places, programmes, to really get to the nub of what our priorities need to be in the next year, the next 2 years and beyond, and identify areas where we can collaborate across places, do things once at West Yorkshire level, and we've got some of this already, but more needs shaking out. We've got some engagement activities coming up in the next month, which I won't labour. More work on the measures, finalising governance and reporting, and as Kate has already said, we've got a kind of desire to regularly come back to partnership board and maybe do a deeper dive across some of our people plan themes. So that's it, I think. Jonathan, yeah, thank you. I think we can stop sharing now.
Well, just a final comment from me, if I may, Councillor. One of the other aspects that Joe's team has worked on is the progress sort of timetable across every single one of those slide actions that we showed up very briefly there and that are in the pack, so that there is a RAG rated delivery plan which is available, which we would be very happy to share. The team were just taking me through it over the last couple of days, but if that's useful for people to see against every single one of those current actions, then that is available to share with the board. Thank you.
Thank you. Thanks very much. So I've got a number of people wanting to comment on this one. So if you want me to bring 2 or 3 in, and then perhaps cluster any responses, starting with Rob.
Yeah, just a comment really as part of the presentation. I think it's important for us to recognise that there has been an increase in staffing in social care in the NHS. But the thing that strikes you when you look at it immediately is that the rate of increase in doctors in hospitals is significantly higher than the rate of increase in general practice, which is higher than the increase in social care. So we've got, you know, I would argue uniform pressure on the system in terms of what people need, potentially even greater needs in community and primary care over the last couple of years because of what's been going on in the pandemic, but differential growth more towards the specialist end of things. So we know that if we're going to focus on prevention, primary care, community services, we've probably got a bit more of a job to do than we might have otherwise thought. That sort of strikes me pretty immediately from the analysis that we've seen.
Yes, thanks, Rob. Sue Proctor next, please.
Thank you. Really welcome all the work that you've presented to us. And I was very struck by your phrase that we want to provide an enabling function. So in that context, which I think is really welcomed to help us sort of raise our eyes to the strategic challenges of the workforce, I wondered if you could comment on how we're taking opportunities of engaging with the higher education sector, not just as an access for professional pipelines of workforce numbers, but to create creative, strategically exciting opportunities around research-based careers, R&D funding, because we know this is a huge incentive to attract and retain the best clinicians and others across health and social care. I'd hate for us to miss that opportunity.
Thanks. Do you want to come back on those first couple, Kate?
Thank you. Well, I wasn't planning to say much against Rob's comments because I was nodding away with them. I think I fully agree. I think we've got to really look at where I think everywhere is a priority, but where the priority focus is from you know, the sort of the recruitment focus indeed. In terms of the comments and the question that Sue's raised, and I think this comes back to some of the work with the Workforce Observatory, which I know, Jonathan, you've put your hand up, so I'll bring you in a moment because you've worked on that so far on my behalf. But I do think that there's a key priority here is to recognise exactly what you've just described, Sue. It's not just about current roles and careers, it's about that whole future piece around skill sets and research opportunities. Jonathan, do you want to come in on any of the aspects that you're already familiar with, please?
I was just going to raise the opportunity that the observatory presents to us, really. So yeah, we're working with both Bradford University and the combined universities. The idea of this is to look at things in a different way. So, for example, one of the pieces of work we're doing at the moment is having a look at the way in which services are delivered around radiography and radiology, as an example. And one of the difficult things about workforce planning is understanding what impact does digital have on that? What impact does research have on that? How could research actually enable us to find better ways to deliver? And so whilst it's early days, that is the kind of territory we're trying to get in. And of course, we do welcome any conversations with higher education, further education institutions that can help us with that. So gladly be pointed in the right direction if that helps.
Thank you. Okay, can I bring in Brodie Clark next?
There we go. Sorry, two assumptions and two comments really from me. The two assumptions I'm guessing are firstly that this overarching plan binds place in terms of the way things progress from here on. The second assumption is that any recalibration of provider requirements will be done by providers. You will not be offering or suggesting other ways of recalibrating the business. What I'm getting at is that there's lots of new ways of working come into play over the last couple of years. There's lots of deployments of digital. There's lots of self-management issues in the community services. And we will be recalibrating our requirement accordingly. In some areas that'll be more, in some cases that'll be less. But I just wanted, I think, to assume that that's for us to do. You have no plans to consider that as a piece of work that might come from the centre as well. The 2 points I wanted to make was, one, it would be really, really helpful because, my goodness, wow, it took my breath away in terms of the detail, the care, the thought, and the process that's gone through to get this far. If there was something, Kate, I might suggest at the end of it that says, and this is what we'll get. We'll get a workforce that costs less. We'll get a workforce that's more agile, that's more flexible. We'll get a workforce that performs better. Just a kind of summary in layman's terms to say, this is where that journey takes us. And that's why the journey is worth making in every aspect of it. And then the final comment from is something about the international overseas recruitment package and agenda. I was slightly saddened, I have to say, that going through the plan, there were only 2 small paragraphs reflecting our overseas work. I think they're a tremendously important group who could be easily badly treated in coming to this country. And I would really encourage some focus on making sure that the proper plans are in place, the proper reception is in place, and the proper treatment of them is in place. The main problem is they want to work 7 days a week, and indeed there needs to be huge care taken in their lifestyle and their working contribution. I'm sure that's there, but it would be good to have read it or seen it somewhere. That's it from me, Kate.
Thank you. May I come back?
Yes.
Thank you for those comments. I think really helpful. And certainly that last point you mentioned there about international recruitment. I think it's perhaps an example of my point at the beginning that to try and articulate the huge summary of activity means it's at quite a high level. And I saw Jonathan nodding from the work that he's leading on around this whole agenda, that there is a lot of detail behind that, which we would gladly take people through, but clearly it's not possible to cover everything in this setting. But you're absolutely right. There needs to be that whole piece, not just about the recruitment, but it is about looking after people and all the cultural aspects there. I very much welcome your comment there around the outcomes and actually articulating what we will get at the other end of all of this work. What does success look like in my words, and how are we achieving that? And I know Joe touched on the measures of achievement, but there is something more about articulating that very, very, very clearly. I picked up your earlier points there, Brodie, as well around place plans, and absolutely we see the two, this sort of overarching people plan with the place plans that very, very closely aligned. I had in one of my induction meetings on Wednesday a meeting with the Wakefield workforce place lead, and very much that was what was being discussed was, you know, we're looking at our plan, we're updating it, but we're making sure the two are very much aligned from that perspective, absolutely, rather than having 2 very separate documents from that perspective. And I think they were the key points that I picked up, hopefully. Thank you.
Thank you. Just got a couple more people want to comment. Just say I'm aware that one of the presenters for the next item has limited time, so if I could ask Kathy and Fatima to be brief and then sum up quickly, Kate. Kathy?
Thank you, Chair. So, Kate, I do have quite a long question, but as our Chair has asked me, I'll be brief. From my point of view, and I think as everyone knows, but I wanted to reiterate this, your role particularly is new and it's different because it's about taking a whole view of our health and care workforce, thousands and thousands of people across different sectors and different places. So I think what you've presented today is very welcomed. I really like the way in which that you've broken it down and really clearly made the information and plans accessible. I think, Kate, if we can meet separately to discuss this as part of your induction, but I do have a question about how we look at a whole workforce, how we look at non-clinical, how we really support and embrace and enable multidisciplinary teams, how we grow our own for the future, and also how we work with the private sector. Our local authority colleagues are very aware that some of them are sitting with unemployment rates that they are the UK average, some of them are higher than the UK average, and there we are sat in the NHS with staff shortages. So I think there's some really simple things to look at together, as well as more complex things, and this is going to be difficult. But the future of enabling someone to grow their career in West Yorkshire and passport across sectors and places and services is what we're trying to achieve here. So if you can weave that in future reporting, I'd really welcome it.
Thank you. And Fatima.
I'll keep it really brief. So firstly, really pleased to see the linkages of the plan with the system ambition about a reflective workforce and enabling them to fulfil their potential. I suppose in the belonging pillar, I wonder whether there's an opportunity to amplify the lived experience of staff within our organisations. So as a network, we do that really well, but it's very focused on race equality. And I wondered whether, building on our aspiration to consolidate what we've done with race equality with other protected characteristics such as LGBTQ, is there a chance for us to do that and really get the biggest bang for our buck? And then the final bit on data was, we are trying really hard to get an insight into the partnership as a whole, so the care sector, the VCSE sector as well, and the medical res is due to come out this year too. So I suppose it's an offer of us collaborating to pull all those data sets together to see if there is an opportunity for us to do some really targeted and focused work. We're absolutely behind this, and I'm really grateful for the support from colleagues in the People Directorate.
Thank you, Fatima. Very briefly, yes, please, in terms of the offer for help, and I fully agree with your reference to lived experiences. I think for me, one of the biggest priorities is around the retention agenda. And I always have a view that we can't really start to fully understand that without asking people what their own experiences are, and that's how we start to prioritise the impact, really. But thank you all.
Thank you. So a lot of really valuable discussion there. I'm sure we're happy to agree the outcomes identified in the paper. A lot of good comments in the chat as well, which I hope people will have time to pick up on too. So the next item is about improving the discharge and flow of patients. Can I ask Karen Jackson and Richard Parry to introduce this?
Thank you, Councillor Swift. For those of you who don't know me, my name's Karen Jackson. I'm the Chief Exec at Locala, and with Richard and Penny, we lead the task and finish group around discharge. Given that Richard has limited time, i.e. 7 minutes, I thought it might be helpful if rather than present all of this, I asked Richard if he could talk about some of the things that we want to do outside the hospital. So you can see from the paper the amount of work that's been done in the last 6 months. I just want to say a massive thank you to all the places and all the organisations that's been involved, because this is not just about discharge from hospital. This is about voluntary sector, community services, general practice, and all the groups who've been involved with us. So the unpaid carers group, personalised care, the workforce group, Kate. So that's been really well connected to this work through Jonathan. So I think what I'd like to do is, if it's okay, hand to Richard and ask him to talk about some of the next steps we want to do, thinking about particularly the out of hospital solutions to the discharge challenges that we're facing, and then I'll perhaps pick up some of the key themes. I've also got some colleagues on the call with me who do an extraordinary amount of work, so Deborah Taylor-Tate and Lou Auger, so they'll be here to answer some of your questions too. So Richard, can I hand to you at that, and then we'll do it backwards? Is that all right?
That's fine. Thanks, Karen. So
Thank you.
For colleagues who don't know me, I'm Richard Parry, Director of Adult Social Care in Kirklees, but I've been working with a number of colleagues across West Yorkshire on this programme. And again, my apologies, I do need to leave. So I think one of the things that struck me about this piece of work is the extent to which it has energised activity across all sectors. So it has felt like a truly kind of multi-agency approach. And within that, we've had really helpful and significant input from the care associations, which represent independent sector care providers. So again, it's moved us beyond probably having some of the conversations with some of the people we normally have conversations with, and broadened that out. I think it's generated a set of communities of good practice across West Yorkshire. So very much people starting to connect and say, we're trying to solve an X. So I had a conversation or an email recently from colleagues in Leeds saying we're trying to do some work around how we could delegate functions, some social care functions to other colleagues working actually within the healthcare system to free up social work, social care capacity. Have you got any guidance on that? Have you developed anything in other places within West Yorkshire? So I think what this programme is going to do is shift that balance to us needing to think not just about what happens within the four walls of the hospital, but the right community capability and capacity. Follows on very nicely from the conversation about the people plan, and actually how do we have a systemic approach to planning for workforce across the entirety of the health and care system. It is, I think, going to require us to think about different deployment models. So actually we know we sometimes this will potentially be at risk of needing some new investments. Sometimes I think we have the investments already within our system. It's just that those investments are in staff in the wrong parts of the system, and we will need to move some of those staff around the place. And I think there's something which has come out of this for me, which is about actually how do we focus on the ideal combination of admission avoidance. How do we keep somebody in their own home, the help that they need to stay in their own home wrapped around them? Or if that's not the case, what is it that we all need to do in a very organised way to get that person back home again as soon as possible after a hospital admission, with the support that wraps around them, the health and social care support, the broader community support that will enable them to get well quickly, to regain their independence, so to become rehabilitated, to live independently thereafter. And that feels like a very different rephrasing of the kind of discharge conversation from how do we get people out of a hospital bed, but actually talks, I think, to the values that we've got as a partnership and as a system, but more critically, I think, has required us and will require us to think longer term. It's not just actually how do we respond to the next crisis, but what are some of those longer term actions we'll need to put in place around the right capacity in community, the right capability in community, having the right workforce, thinking and planning holistically for an individual, so thinking about the end-to-end journey for an individual, not just each bit of the system doing their job well, and thinking about some of those changes that, as Karen suggested, won't bear dividends this year necessarily, but actually if we don't start doing them now, we won't get the benefit from them in 2023, 2024 and beyond. And that's quite a different, I think, shift in thinking. It requires all organisations to not just focus on the immediate challenges, but to plan longer term, to lever some of the things like the workforce plan to drive some of that longer term change. I think the other bit is told us that there's an importance to a set of clinical roles, but actually it's that broader community capacity that helps people stay connected in communities that's going to be equally important. And that's something that we all have a role to play in, but clearly I would suggest local authorities, in particular with some of those broader roles that they have available, has particular kind of contribution to make. And there's a challenge in all this about how we keep the right balance between a separate discharge programme versus actually translating this into this is the way that we'll operate business as usual in each of our 5 places. It's the way we'll plan for workforce in the future as part of a business as usual approach, and actually sharing best practices now just part of the DNA of the way in which this partnership works. So I'm wondering, Karen, whether I could just hand back to you now, if that's okay.
Absolutely, and run away. That's fine. Thank you, Richard. So you can see from the programme that we have developed a 10-point plan. It is based around the places and everybody in the place. At the moment, we are very focused on making sure that we have mapped all of the work so that we make sure that it's collected either in an organisation or in a place, or where appropriate at the ICS level through the appropriate work streams that we've got in place. So I'm thinking there particularly about things like anticipatory care, workforce and virtual ward. So that is in progress at the moment. We have some recommendations in the paper for you to consider in terms of the content of the paper and the strategic aim about how we care for people. I call him Fred, how we care for Fred in the place where he lives, however old Fred is. And also the some actions and some next steps about thinking more long term, the governance piece that we're in the process of, the mapping, making sure we've got that appropriately in place, consideration of the resource movement that Richard's talked about, and consistent approaches to this. So I'm just going to check with Lou or Deborah if they'd like to add anything, and then perhaps we pause for some questions. Councillor Swift, if that's okay.
There's nothing from me to add. Thank you, Karen.
Thank you, Debs. If she's there, she's talking to herself. Thanks, Councillor Swift.
Okay, thank you very much. So let me invite any questions or comments or observations on this piece of work and proposals. Yeah, Fatima, yeah.
Thank you, Chair. So the Race Equality Network were really supportive of the approach in the paper, but there were a couple of areas where they thought it could be strengthened, particularly from the angle of cultural competence. So, for example, if an individual was discharged into the community, how do we ensure that services, whichever sector, are culturally competent and delivering care in a way that that person can relate to or can access? And in particular, while they're in the hospital themselves, whether they're a carer or somebody receiving services, if their care plan is changing, how do we ensure that that person fully understands the implications of that and can access support in a way that is meaningful to them as well. So there's an offer of support of insight if needed, but we just thought it could be strengthened in that particular area.
I'll pick that up with you, Fatima, outside, because yes, we need. I certainly will need some support on that. So yeah, I'll pick that up with you. Thank you.
Thank you, Kathy.
Councillor Swift, I think Brodie was before me.
All right, okay, sorry, yeah, you're right. Brodie, I do apologise.
Really, just to say, I thought that was a brilliant presentation from both of you, actually, and I think the work that's been going ahead, Karen, has been absolutely super. I think just to mention that in parallel with that, there is some work going on in terms of community collaboration between chairs, chief execs, and bringing that across together within the ICS footprint. That met about a month ago, and it felt to me as though it was beginning to have a bit of life to it, a bit of direction, and a bit of commitment around it. And I think we want to use that vehicle to take forward some of the work that's going ahead with Karen and her team in terms of the spread across West Yorkshire. So there's a parallel piece of development, but it's together and it's joined, and it looks to be moving forward constructively. There are many, many ideas at the moment around about hospital and getting into community. I think my abiding thought is this is about flow right through the whole system, not piecemeal activities from one bit to another, which is probably causing difficulties further upstream or further downstream. So the focus and flow is critical. But my goodness, the heads are there, the hearts and minds are there. For example, in Leeds, we're working very, very closely now with Leeds teaching hospitals in terms of finding ways of moving who are ready to go home at a very early stage for them to go home and receive their care there. But brilliant stuff, Karen. Thank you.
Thank you. Kathy.
Thanks, Tim. I particularly also was helpful for Brodie to go first, because I was also going to talk about the emerging community services provider collaborative at West Yorkshire, which will then sit alongside our provider collaboratives for acute services and for mental health, learning disability and autism. And Karen, you already know so much about this, but I think there's something in your paper about strengthening the governance and greater connectivity. And I think those two provider collaboratives across acute and community can provide that. And informal discussions I've had with provider chairs across the whole of West Yorkshire is, let's make sure provider collaboratives are talking to each other as well as places are talking to each other. So I think there's something about give us the people that work in governance and a to-do list in some ways that we can then try and work on strengthening that governance. And then there's something about both of those provider collaboratives, acute and community, want to have a better understanding of community services. I think we could all sit here and talk it through together about how we all have the same understanding and benchmark of that. So I hope that's something can emerge, particularly out of the new community provider collaborative. But I feel it's one of my jobs over the next 12 months to help that connectivity as well. So I hope we can keep talking. But I think there is something there strongly for leaders in this forum and on the Integrated Care Board for West Yorkshire around that community services capacity and capability and strengthening the governance arrangements. So I'm happy to be part of that.
Thanks, Kathy. Absolutely agree. And we have taken this into both the community collaborative, the community services collaborative, and also I was invited to go to WIAT, and I've had the discussion at WIAT and got great support for what's being proposed here. So that's helpful.
And sorry, Tim, just to come back, this is going to be difficult. It's messy, isn't it? But we'll find a way. We're such a strong, good partnership. We'll find the way forward for that as well. But I think it's these difficult conversations or mapping it out that will help us all. Thank you.
Thank you, Kathy. Could I go to Len Richards next?
Yeah, thank you, Councillor Swift. Myself and Karen have had lots of discussions around it, and we've talked about how we sort of approach this. But one of the learnings that I've had working with the Canterbury District Health Board particularly, and I think it plays to some of the points that have been made, is how do we ensure that our data tells the story about how our system works, not the story about how our individual organisations work, which I think is what we rely on at the moment. And that requires us to join up our data across all of our systems and to understand how patients or residents of our communities actually access our services, whether it be in the community, the hospital setting, the ambulance service, etc. And I just think one of the challenges in that, and I'm only highlighting it as a challenge, is the information governance challenge of joining up data. It's something we're working through here in Wakefield, and it's something we will work through with Karen and teams around this whole application. But it is a challenge, and it may require us to think about information governance and how we as system leaders want to I guess overcome some of those challenges so that we can understand our systems a bit more.
Thank you. Just following Robin, because I just wonder if I could just ask a couple of questions, make a couple of comments as well. I sort of wonder, I suppose two things that link together really. One is I wonder how I'd be interested in how you're looking to involve the voices of patients and families as well within this. And I notice, it's probably a case of me not keeping up with the changing NHS language. I noticed there's a new to me piece of jargon about what's it, criteria to reside or something, which I assume is an alternative to sort of medically fit to discharge or whatever. And I suppose the point I want to make is that somebody may be medically fit to discharge, but actually are they psychologically and in terms of their social families and supports ready to be discharged? I'm very aware when you discharge somebody quickly from, someone may be technically medically fit to discharge, but you may be sending them home with all manner of tubes and medicines and service needs. And I sometimes wonder if we think enough about the demands that makes on the carers and families in all of this, and the access to immediate support and advice that people require. Should I bring Robin and then come back to you, Karen?
Yeah, thanks, Chair. Thanks, Karen, and thanks everyone for the work. I think there's two points that I want to make, and then something I want to ask really. So the points are, firstly, this is really core business, isn't it? This work, this is why we do this. This is why we collaborate at each level, so that we can change the way that services are delivered to better meet the needs of people. I really like the way Richard reframed it. Rather than being about a process within the system, it's about people. But we've got to get this right. The second point I wanted to make is that it's good to have. I fully support this idea that we take a bit of time to get this right for a sustainable model. At the same time, we need to recognise that immediate risks and issues for us in terms of flow. So I can see Len and the situation on the Wakefield side of Mid Yorkshire has been tough recently, as I can see Brodie and the position in Leeds as being of national interest around flow in the system. So we do have these daily realities and pressure that we will have to contend with whilst we take the time to do the right thing. And that's just the reality that we're in at the moment. But we mustn't let the sort of immediate get in the way of the sustainable and the long term. So I'm pleased that we're taking this approach. I think the question that I've got is, what's our appetite here? Because on the face of it, the recommendations are saying that we will share data, we will move resources around the system to where they need to be deployed, and we'll do that in a way which means that people get the best opportunity. And that's in the context of us receiving a workforce report that says we've had workforce growth, but it's been much more limited in social care and general practice than in hospitals. So I think what we're laying the ground for here, I think, is what might be some quite radical actions that people want us to take. And I think that's good. I think that's right. We do need to be aware that that's what we're saying. We're laying the ground here for some recommendations that might be quite radical in the future. So the question is, do people clocked that, and are they happy that that's what we're doing?
So do you, in terms of the conversations we're having in the work programme, that's exactly the conversation we're having, and that's what we're trying to make sure is socialised around every place, but also around the ICS work streams. The idea that if we really do want to take care of Fred in the place he lives, we're going to have to do some things quite radically different. So certainly from the work programme, Rob, that is what we're trying to get the message. But I'm really grateful for the question that you asked there and the support you're almost saying, you know, that's where this is going to go.
I think in a sense, sorry, Karen, you carry on. I was going to say, I think in a sense we've almost taken the lid off the jar, and there are things there which are created, which are quite different, which just make good sense in terms of the flow. And I think there's an appetite for that. Our transfer of care hub, which is now beginning in the teaching hospital, that's going to take off. That will produce positive results along the lines that we're speaking about. And I think it is a forum where people will be able to say, hey, what about? We're doing something over here. Let's try that over there. I think that's around.
Thanks. Sorry, Karen, have you finished? Was there anything else?
Well, and just to say, Councillor Swift, you're dead right about patients and their families and carers. That's why, first of all, we want to be very connected with the unpaid carers programme and the personalised care, which is fortunate because I've got that joint SRO right with Richard as well, so we can make that joint up. I will say that I don't think we've done enough on that and the voice of patients yet. So we've clearly in place has got more to do on that, and we will continue to be absolutely focused, and that's why I keep talking about Fred. This is my imaginary person, but this is about people. Yeah. So that's why I keep talking about our person, to make it real. Thank you.
Thank you. Okay, any more on that?
Sorry, Councillor. Just one last point that's not being made, not to torture it too much, but Karen did talk about Fred being any age. We have talked about children. I'd also like to recognise that there are issues we'll want to manage and support around people with learning disability and people with serious mental illness too.
Absolutely, Rob. Yeah, and we've connected mental health into this programme best as we can now.
Yeah. Okay, thank you. I was just checking in addition to the sort of next steps. I don't know if there's anything just to add, Karen, in terms of where this work reports back in the future, and if there's a point when it will perhaps come back to the partnership board again. Yeah,
it will come. It will. Our intention is it will come back. We report regularly through the ICS, as it's called at the moment, the ICS process. So yeah, when we've made some more progress on the action plan, and I'm particularly keen that we all understand the mapping, so yes, that we can make sure the governance is straight and we've got the assurance that we want in place, so that we know we're making a difference and not just talking about it.
Thanks, Karen. Rob.
So I think as we move to the new arrangement, the way that I would want us to think about answering that question is this partnership board, creates the strategy and sets the direction, and the integrated care board has to deliver it with its partners. And I think what I'm hearing is resounding endorsement for this work, and what we then need is the integrated care board to get on with it with its partners, and to escalate issues to the partnership board where there are issues, I think, but the oversight through the integrated care board as an organisation within the system should be such that progress is monitored and assured as a mainstream priority.
Thanks, that's helpful. Yes, I agree. Okay, well, thank you everybody for that item. We now reach a point on the agenda where proposal is we have a short comfort break. It says 5 minutes. My experience is that that's rarely achievable. So I'd suggest we restart at 15:40 if that's okay. But I will start things going then, regardless of who's back. So I hope that gives people long enough to boil a kettle if that's what you're after. Thank you. Let's go. So welcome back, everybody. And I'll take straight into our next item, which is the update report on tackling health inequalities for Black, Asian and minority ethnic communities and colleagues. And welcome Fatima, Keir and Kaniz to present this item. So over to you.
Thank you, Chair, and apologies, I'm wearing multiple hats today, but just for the benefit of this agenda item, I share the lead responsibility for the oversight and delivery of this review with the fabulous Sarah Smith, who's not here, but with a lovely baby girl. So she's got a very good reason for not being with us this afternoon. Before I begin the agenda item, can I just introduce Keir and Kaniz? Keir, do you want to go first and just introduce yourself, please?
Thanks, Fatima. So, hi everyone, I'm Keir. I'm the Programme Director for Mental Health, Learning Disability and Autism across West Yorkshire.
Thanks, Keir. Kaniz?
Hi everybody, I'm Kaniz Khan. I'm the VCS Voices Chair for the race review.
Thank you, Kaniz. So I'm just going to attempt to share my screen, and I have been technically challenged this afternoon, so someone please shout up and let me know that you can see my screen.
Yes, we can, Fatima.
Thank you, Lauren. And can you tell me if it changes?
That's working perfectly, thank you.
Thank you very much. So my apologies, Em Irving is doing a slightly different webinar session, so I'm going to cover her section for this particular agenda item this afternoon. So just to remind colleagues about the format of this particular agenda item, because there are 4 sections within the review, this afternoon we're focusing on theme 3 and 4. Theme 3 is the population planning, using information to make sure that services meet different groups' needs. And theme 3 was that. And theme 4 is reducing inequalities in mental health outcomes by ethnicity. So just to start with theme 3, the Population Health Management Programme, as you've heard in the previous 2 agenda items earlier on in this meeting, I've been doing absolutely sterling work to progress some of the recommendations in the report. In particular, one of the decisions that we've ratified today, which is to make us one of the first ICSs and partnerships in the country of Sanctuary, which was a specific recommendation as part of the review. In addition to that, we have launched the Health Equity Fellows Programme, many of the members of which are on this call this afternoon and are planning for year 2, just to ensure that we are creating a sustainable approach, embedding the work on health equalities across the work of the partnership. In addition to this, and this is fantastic news, the programme has secured £200,000 worth of funding to support targeted CVD prevention, that's cardiovascular, colleagues that are not sure about the acronym working, between primary care networks and the voluntary community and social enterprise sectors. And this is particularly relevant because we knew through the work of the review and some of the testimony the importance of an emphasis on prevention, and that services were really focusing on the needs of specific communities rather than a one-size-fits-all approach. Another element that I think is really important, and it's one of the reasons why many colleagues have had to leave the call to undertake the training, is a real action focus on the impact of the evidence of people that have experienced adversity, trauma and resilience, and the implications that can have for people accessing services. So one focus of this programme has been to really focus on the lived experience of migrants and refugees on this particular area, but also to work with our partner organisations, because obviously as a system and as a partnership we have massive influence across the region, to really support organisations to understand the implications of this in the context of racism and trauma. In addition to this, and again another area of us not only just focusing on rhetoric but supportive action with resources, is £80,000 worth of funding focusing on targeted prevention to reduce inequalities for the 2 focus groups at the moment, which are gypsy travellers and refugees and asylum seekers. And as you can probably see through these bullet points, there is a golden thread of us trying to do a sort of a multifaceted approach of focusing on a specific area to really consolidate impact, because we know that this has been an area that has been sadly overlooked for a good while and needs a really systemic intervention when it comes to improving outcomes for those particular communities. And again, links back to some of the testimony that we heard a couple of years ago. I think one of the most important elements, though, is this £10,724,000 that will be supporting the work on the Core 20 Plus and the voluntary community sector organisations for a real joined-up approach to support targeted reductions in health inequalities. And this goes back to our work on subsidiarity of place, about delivering resources to the closest parts of people's communities, their neighbourhoods, to really make sure that we can really amplify the good work and learning that we've discovered through this programme. In regards to where we go from here, I think one of the important elements is to ensure that the work that the Health Equity Fellow Programme undertakes is evaluated to make sure that we're taking all the learning and maximising the good practice. Year 2 has already got 30 Health Equity Fellows waiting and 30 Adversity, Trauma and Resilience colleagues. So there's already a massive group of individuals that we can tap into regarding their expertise, but also to amplify their work across the system. In addition to this, the Health and Inclusion Unit, which Em alluded to with Robin earlier, will really help us focus and understand health inequalities for specific groups, because we all know that not all BAME is the same, but also that even the intersectionality across a number of protected characteristics may require specific interventions. And this is where we can really add value by working at scale. In addition to that, there is also the work that we've been doing so far as a partnership with our collective leadership and shared responsibility with the allocation of the funding, but also to understand the impact of that funding and where necessary to repivot it to make sure that we are continuing to deliver the best outcomes for the people of West Yorkshire. I'm going to pause there and hand over to my colleague Kia now, who's going to talk you through the work of the Learning Disabilities, Mental Health and Autism Programme. Over to you, Kia.
Thanks, Fatima. Yes. So from our programme's point of view, following the publication of the review recommendations, we got clear agreement from our West Yorkshire Mental Health, Learning Disability and Autism Programme Board that there were 8 actions for the programme to lead on and a further 9 where we wanted to make a contribution to across the wider review. And we agreed to report monthly back to the board on progress against those actions. So after a period of time, and when we got through to March this year, we've considered the progress throughout the year and identified what's happening next against those actions. So I'll talk you through those now. So there were essentially 5 actions from the review that we now felt had been completed or didn't make sense to continue at a West Yorkshire level. So these were, the first one is around actions relating to the Staff Mental Health and Wellbeing Hub. So this is essentially around how we ensure that the same therapeutic offer that the Wellbeing Hub provides to statutory organisations is available for VCS organisations too, including the same access to online resources. So that was always an ambition for our Wellbeing Hub. We didn't want it to be something that was just for the NHS or just for statutory organisations. It absolutely included all elements of our partnership, and also that rollout of any training packages, things like critical instant debriefing or mental health first aid awareness, were also available to VCSE partners too. So all of that was completed, but it is worth saying that we acknowledge that we still know that that awareness and messaging around that availability of the offer to all VCSE partners hasn't necessarily filtered through to all partners in our place. So we're continuing to try and raise awareness of the fact that those offers exist for our partners, and that we can use system and place-based communication routes to make sure that VCSE organisations get access to the hub and their staff do when they need it to. The second action that we feel we've completed is about facilitating some of the staff secondments between VCSE and health organisations. And the reason why is that through our work on community mental health transformation in each of our places, we've shared the examples from a system point of view of where that's worked. And our trust partners are progressing closer working models between trusts and VCSE organisations at place. So that again is not to say that there are partnerships in place everywhere, but from a system point of view, we've kind of started to stitch together what is working so that partners know what is happening. We have also, as a third action, now established, one of the actions was to establish a public mental health leave role across the partnership. So the Mental Health, Learning Disability and Autism Provider Collaborative has funded a fixed term consultant in public health to work for the collaborative and across the partnership. So our consultant started about 3 weeks ago, and we're looking to review the early impact of her role and how hopefully that might lead to a permanent arrangement as well. We've also reviewed the ask about setting expectations for workforce training schemes regarding ethnicity targets and how organisations become mindful employers. And it was felt on reflection that this was not a mental health, LD or autism specific ask, but it's something for the wider collaborative that we're contributing to. So it's not that we aren't playing our part in that, but it's not something that we feel we can do out of kilter with the rest of the partnership. And finally, there were some other areas within the initial actions whereby actually on reflection we were making more of a contribution to than leading as a programme. So things about how we identify whether ethnic minorities can get access to kind of green space, collecting data on homelessness, some of the work around inequalities in housing and some of the wider inclusive leadership standards. So essentially what we're saying is there were, of the actions we set out with, there were 5 that we've actually looked at as a programme and gone, we feel we've taken them as far as we can realistically from a system point of view. What that does leave though There's a total of 6 actions that we're taking forward and monitoring quarterly over the course of this year. Now, 3 of those are continuations of work that was started and continuations of previous actions through the review. So the first one is about how we do utilise that consultant in public health role to support the sharing of best practice through the Health Inequalities Academy, including how we network together those folks who are working in each of our places on specific support for mental health for ethnic minorities to get that good practice shared and rolled across the place, and also to focus a little bit more on some of the anchor institutions approaches that we can adopt as mental health trusts across West Yorkshire. The second one we're continuing to take forward is how we support and stitch together our HR teams to review their employment policies and to develop some of the independent discrimination panels with ethnic minority representation. So essentially trying to use the Mental Health LD and Autism Collaborative as a bit of a test case for how we do that in other organisations too. And the final action that we're continuing is about how we develop the community mental health inequalities framework. So essentially, as we are looking at the transformation that is taking place within mental health services in our community and the relationship between primary care, BCSE organisations and our mental health trusts, how do we make sure that we are ensuring that service access, uptake and outcomes are monitored to identify the inequalities that are present for our communities? So there are 3 actions that we are continuing from the previous review, and there are also 3 new actions that we've added in as a programme following discussion at our partnership board. So the first of those is on how we increase our focus on culturally competent services. So there's a range of things within that. So I'll talk through 4 bits in particular. So one is how we are funding an ethnic minority lead within the Wellbeing Hub, who's working with the Race Equality Network to develop appropriate offers for our diverse workforce, so that if we've got staff who are accessing the Staff Mental Wellbeing Hub from different backgrounds, they are receiving care and support that is appropriate to them. The second is about how we develop a cultural competence framework for mental health services with appropriate training. So it links to the community mental health transformation piece. So how are we ensuring that practitioners within our services are equipped with the skills to be as culturally competent as they can be and understand the communities that they serve? The third is about how we're piloting the recruitment of volunteers in BCSE and NHS settings to try and increase some of the diversity we've got within our peer support workforce. So we know that we're utilising peer support workers is a key strand of our workforce transformation in mental health, but how do we make sure that peer support workers are coming from diverse backgrounds? And that's working with organisations such as the Black Health Initiative, MESMAC and AdvaNet to support that work. And finally, on that piece, we're employing a couple of practitioners to work as part of Young Black Minds, engaging in mental health conversations and anti-stigma messaging, and also offering one-to-one support in particular communities. The other 2 actions then, one is around how we make sure that, again, through our consultant in public health role, we prioritise some of the understanding about inequality in perinatal mental health. So for mothers and their partners, after the birth of a baby, and that builds on some of the work we previously commissioned through Born in Bradford, which did identify some of the inequalities that our communities face. So trying to identify what's the evidence base, what do we do around if we know we've got access issues for people accessing support from a perinatal mental health point of view, and doing the same with our trusts on the wider data they collect. So can we ensure we've got consistent standardised collection of data about ethnicity, and are our trusts all asking the right questions in the right way of our communities to ensure we've got robust and appropriate data? And finally, trying to diversify our future workforce. So part of that is about utilising some of the mechanisms we've already developed, things like our virtual recruitment fairs to reach diverse communities. We've established a role working with a VCSE organisation, Touchstone, to try and proactively work with individuals from diverse communities to support them into employment in mental health, LD and autism settings. And then there's a bit for us as well as a programme. So how do we make sure that we role model in our recruitment practices, publicising any roles that we want to recruit to, not just through the traditional kind of NHS jobs route, but making sure that they're advertised in ethnically diverse press and in other areas rather than just kind of relying on traditional routes. So they're the bits in the kind of the action plan we're taking forward, which hopefully is helpful and worthwhile saying as well. Beyond the action plan, we continue to have a focus at the wider West Yorkshire Partnership Board for Mental Health, Learning Disability and Autism on issues affecting specific communities. So just coming up next week. We're talking about a report into suicide prevention within South Asian communities and what we need to do as a system, what we need to do at place, what we can do jointly or kind of individually to make sure we are doing the best we can for those communities too. So it's not just about what's in the kind of the action plan. There are the wider work is important too. But I'll stop there, Fatima, and I think hand over to Kenise.
Thank you, Kira and Fatima. Kira, you just answered all my questions that I'd asked you when we met. And we seem to have made so much progress as well. I have to say that working with Fatima and the team has been really, really positive. We are being heard, and from Kira's, the last bit of Kira's presentation is very nuanced to some of the questions that we had asked from Kira, and the answers have come. So it's brilliant so far. We're very happy with the progress that's been made, especially around the mental health and the fact that there is going to be the public health lead, the mental health public health lead worker that's going to be coming in. Very, very, very happy with that, because we want a more nuanced, targeted approach. Which communities need it the most, and sometimes it's about colour, but sometimes it's not about race. Sometimes it's about where it's needed the most and which areas are the ones that need it the most, and that's the way that we're seeing it, is we should be responding in that way. So we're quite happy with the CVD funding. We did ask about where that went and who was it that accessed it. We also asked some questions around the funding that came, the 80,000 for the community connectors as well. How are decisions being made around commissioning? Because what the easy option is, and a lot of people do this, is because it's the easy, we go to the big, huge organizations that are easy to get to. It's the easy option because they're the VCSE sector and you're partnering with them. But actually, sometimes it's the tiny groups that are working with asylum seekers, refugees, and that are working with Gypsy and Traveller. It's those that are working closest to ground, their local community centres, that are going to be able to get this health messaging across. So I think that's our focus of how we're going to work with the littler groups, and how maybe we can utilise the huge VCSE groups to think about that. And I know definitely Touchstone is thinking about how they're resourcing the smaller groups to help with some of the work that they're doing as well. So that's something that we think is really important going forward. And we're really happy the fact that we've got a space on the leadership so we can help to shape it. Actually having your voice on these panels helps to shape the outcome of what's going. And what's great is the fact that we have insight to what's happening on the ground, and then we can help to shape the strategy of what's going forward, because we directly relate back the experiences. One of the experiences that I know that asylum seekers at this point in time, in the Leeds, some of the Leeds hospitals, are experiencing quite a challenging time when they're experiencing the emergency room. So some of this, if we can directly be that middle, it helps to narrow the gap with health inequalities. So we are quite pleased with the progress that's been made. The adversity and trauma came in last week, and I think she just offered absolutely everything. And some of our panel members are on the training today too. I will be joining the leadership group. They've also been offered to sit on the VCSE Voices panel for the Adversity, Trauma and Community Action Collective. So far, we feel like we're being listened to, our voice is being heard, and I think over the long term, within the 6 months to next year, we can look back and see if we are reaching those that are the closest to the ground to help save lives, to help change the cardiovascular, to help change the mental health accessibility, to help change this. Let's see how we can go together forward. Thank you so much to West Yorkshire Health and Care and the progress that we made so far together. And that's it from me.
Thanks, Kenise. And if I may say it's sort of in summary to some of the feedback we've just heard from the chair of the VCSE Voices panel, a key element of that will be the delivery of the Memorandum of Understanding that Joe Baker and Hilary Thompson from the Harnessing Power of Communities programme have co-produced and led on. And within that, there is a specific reference to grassroots and diverse organisations, because we know the value add, particularly that they contribute to. But in summary, I think what partnership members, I hope you will see, is a significant move from transitioning from the short-term immediate opportunities to address some of the themes from the review to some of the more complex issues now, some of the wicked issues, some of the things that are starting to take time, but we're seeing some green shoots on, which I think will provide you with the assurance that you're looking for, that we are moving in the right direction. I think one thing we will say, and it links back to the feedback from the previous one, is the infrastructure of how we transition some of the elements that you're seeing from a strategic partnership perspective into our places and into our grassroots organisations is something that I think we're moving in the right direction towards, but recognise there's more work to do. But what we asked the Partnership Board today is that they receive the update and support our recommendations, which is to note the progress we're making so far, but equally any expertise, insight on areas of development would really welcome your support on. Thank you, Chair.
Thank you very much, Fatima Kieran-Keynes. Are there any questions or comments on the presentation? Rob?
Well, so firstly, just say thank you for the team for the continuing progress in this area. I think when we started this work, one of my personal challenges to us all was, let's not make this like the ice bucket challenge. You know, everybody sort of gets into this issue when it's an issue that's noteworthy or newsworthy, and then forgets about it, you know, until it comes up on their timeline a year or two later. We haven't done that. We've continued to progress the work around race equity, and I think that's down to some challenging conversations and some really positive work, I think. So I know that Keynes and Fatima and others will be explaining to us what progress has been made. They probably skirted over some of the tough conversations that have had to happen during the process. So thank you to them for the work that they've done. I think the question I've got is for place leaders, really, and for place committees. So as we're setting up these place-based arrangements, I think what Keynes has put forward and others is that, you know, it's knowing your communities, it's working at grassroots, it's understanding neighbourhoods that's going to be important. So substantial amounts of this work are going to be delivered in those places. And just to check in, do we think that there's enough of a focus on this in the 5 places as the place partnerships get going to ensure that progress is sustained?
Thanks, Rob. That's a good choice to take back. Mel?
So I would say probably not enough, and that's because there perhaps hasn't been enough focus on communities being the right place in which to do this. And so as part of our strengthening of our strategic approach in our place to developing resilient communities, it will be a fundamental part of that, and we are starting to build the infrastructure around how we're going to approach that. But it will be certainly something that most sits most comfortably in that particular area of our strategic work.
Thank you. Can I go to Carol McKenna next?
Yeah, I think from a Kirklees perspective, it's probably similar to what Mel said, actually. So I do think there's a good level of understanding of the, you know, particular needs of our communities, and there's been a strong approach to neighbourhood working in Kirklees. However, we are at a point where we're now considering how best we strengthen that, you know, so coming through the pandemic, refocusing the work of, for example, PCNs on the back of the fuller review and the emphasis on communities, and the council have done some fantastic work as well very recently to nominate lead elected members to connect with the 9 localities in Kirklees. So I think we've got a really good opportunity now to almost, I don't know what the right word is, reboot, relaunch, refocus, you know, the strengthen the work that we have in neighbourhoods and pull a lot of what you've talked about today through into that. So it's quite timely, I think, really. It's a timely reminder. Thank you.
Thank you. And Jo Webster?
Hi. I think, like colleagues, we can always do more in this area. I think one of the things that I would add is that when we get this right, we have some significant impact. And one of the examples in Wakefield was the roving vaccination team. and how they connected very differently and had a different conversation to understand the needs and about barriers to access. And I think that's the kind of model that we should be developing in our neighbourhoods, but using every opportunity to do that. So it's about how our staff connect with residents differently as well. So I think there's more to do in this space, but I would give the commitment that we're all, we have this high on our agenda in Wakefield, and we're very committed to getting it right. But I think the roving vaccination team is a great example of really understanding the barriers and needs of this population.
Thanks, Joe. Rob, you want to come back?
Yeah, just I mean, I asked the question partly because I think we're in a transition period, aren't we, between you know, having CCGs and arrangements through them and health and wellbeing boards into place-based partnerships, which are broader and hopefully stronger collectively under the delegation of the ICB. And there's an opportunity for us to think about how this work, which is making so much progress, you know, is amplified at that level. So what I'm hearing is that that's already on people's agendas, which is a good thing. And I guess the question for us is for us to consider what kind of reports we want here as a result of that in the future.
Thanks. Yeah, that's one we should pick up. Okay. I'm not seeing anybody else indicating. So we're happy to note progress and support the steps identified. Thank you. Oh, Kenise, yes, you want to come back?
Can I just come in and offer our help? So if you, any of the place needs support with this, we're more than happy to convene meetings with some of our members so you can get, because the experience of Gypsy and Roma in Keighley is going to be very different from the Gypsy and Roma in Leeds. So can we just offer our help if that is needed? And we're more than happy to support in any way so we can get some more closer insights to the ground with the connections that we do have.
Thank you, Kenise. And Fluke?
Thank you. Thanks for that presentation, really helpful. And actually, the final comment there relates to what I was thinking about and how much this is really important in relation to the personalisation agenda. So I was thinking about the work you've done around competency, cultural competency, for example, and how we ensure that whilst, yes, I might have an understanding of the Bangladeshi, a better understanding of the Bangladeshi community, I select that just that's the one top of my head. It doesn't necessarily mean that every individual that I meet from Bangladesh wants an interaction in the same way. And therefore, we need to make sure that the way we deploy and the way we work with our communities is very cognizant that there isn't a one size fits all just because you're from a Black and ethnic minority community or you are classed as deprived or have significant inequalities. And I just really think, and I guess it's the visibility of the connection of that to the personalisation agenda would be really helpful.
Can I respond to that, Chair?
Yeah, sure. Yeah.
So as the lead for personalisation for Luke, it is very much on our radar. I wanted to assure you with that. But I think the point you make is really important, which is, you know, as someone from Pakistani heritage, which is literally like 2 countries away from Bangladesh, we're very different, but we're all called South Asian, aren't we? So that ability to be able to see people as individuals in a holistic way in compared to sort of sweeping, well-intended generalisations is so important. And in response to sort of Rob's challenge, I think one of the things, Chair, if I may take away as an action, is an opportunity as we evolve into place-based working. It would be great to see an evolution of the work of the review with a place-based lens, to see how we're responding to it as places with supporting plans of action, because that is where we're going to get the momentum and the change. But that is something that will need to evolve through time as we're on a journey, aren't we?
Okay, thank you. Thank you. Yeah, that's helpful. Okay, thank you. If that's okay, then I'll move us on to the last agenda item, which is Integrated Care Board Constitution and Governance. And Stephen Gregg. Stephen, can I ask you to introduce this?
Yes, thank you, Chair. Yep, for anyone who doesn't know me, I'm Stephen Gregg. I'm the governance lead for the partnership. And I've been working with the ICS Governance Working Group, chaired by Tim Riley, Accountable Officer for Leeds CCG, and including representatives from across our partnership. As you'll be aware, the Integrated Care Board will be established on the 1st of July, and this report presents the final ICB constitution as agreed by NHS England, and also work in progress on the ICB governance handbook. Acutely conscious that there's an awful lot of documents here, many of which you will already have seen either in this forum or in your place-based forums. And one thing I just want to say is thanks to everyone on the ICS working group who's contributed to these documents. It's been a really good collective effort, I think, to get to where we've got to today. The governance handbook is designed to give us flexibility to adapt our arrangements, and none of the documents or the arrangements that will be in place on 1st of July are set in stone, but we absolutely know that we'll need to adapt and refine them in the light of learning from operating in statutory form. The one fixed point really is the ICB constitution. That is the document that needs to be approved by NHS England, so any changes to that we need to get authorised. So we've adapted our draft constitution to reflect the feedback we received from the extensive involvement we did both with partners and stakeholders. It's now been approved by NHS England and is attached at Annex A. Following approval of the constitution, we're on with the nomination processes for partner roles on the ICB board, and all those nomination and appointment processes include a commitment to improve the diversity of the partnership's leadership and to ensure a good spread of representation across our places. As we've heard in the previous item, our principles of subsidiarity mean that the ICB will primarily discharge its duties through delegation to ICB place committees. So most decisions will therefore be made at place level in support of local health and wellbeing board priorities. The governance handbook sets underneath the constitution, sets out the detail of our decision-making arrangements, and the latest draft of that is at Annex B. This remains very much a work in progress, and then much of the content will be refined further, both pre and post 1st of July. The one missing element at the moment from the handbook is the draft risk management framework, which is being amended in the light of a workshop that we had at the Shadow ICB board meeting on the 17th of May. So I've just set out for today some of the key principles on which we're going to base that framework. The handbook itself is split into two main sections, the first of which is a very high-level summary of how we make decisions, which really kind of seeks to set out a stall of our approach to decision-making in West Yorkshire. So it's anchored in our priorities and the outcomes that we want to achieve, focuses on subsidiarity with our functions and decisions map, setting out that delegation to place, alongside our commitment to hear people and communities' voices and the work that's being done around that to develop new arrangements, set out our wider partnership governance arrangements, and I think importantly, examples of how we work together, both within place, working across places, and through provider collaboratives. So we've set out some kind of case studies which seek to set out how we work in all those ways across the partnership. And we plan to add to these case studies post the 1st of July as we get to grips with working in this new statutory way. And alongside that high level introduction, we then got the detailed governance arrangements, the scheme of reservation and delegation, standing financial instructions, terms of reference for each of our key committees, the Partnership Board, Place Committees and West Yorkshire Committees, and then some of our key policies around conflicts of interest, standards of business conduct and our public involvement framework. And you'll see from the drafting notes and the track changes that are still on a number of these documents that these are all still very much in draft, and comments are welcome as we refine them ready for the 1st of July. I just won't go into detail on the documents, but just highlight some of the key issues. In relation to the Partnership Board, that will become our Integrated Care Partnership, which will agree our Integrated Care Strategy, and it will be formally established as a joint committee of the local authorities and the ICB. As set out in the terms of reference, which the Partnership Board agreed in 2021, the chair of the ICB will be the deputy chair of the partnership going forward, and we'll need to refine the terms of reference to reflect the board's new statutory status. In relation to ICB committees, as I've said, key to subsidiarity is the place-based committees in each of our places with delegated authority, but alongside those, we're also proposing to establish a small number of West Yorkshire level committees to provide the board with assurance in carrying out its key functions. These include 2 statutory committees, one of which is audit, the other is remuneration and nomination. We're also proposing a finance, investment and performance committee and a quality committee to provide assurance on those key areas. One of our governance design principles has been to streamline arrangements where we can and build on existing governance. And we want to ensure we've got robust assurance whilst avoiding duplication, attendance at multiple meetings and unnecessary layers. In relation to this, it's proposed that with the exception of Health Watch, sector representatives are not formal members, regular members of ICB assurance committees, but are invited to attend depending on the specific agenda item under discussion, and views on this proposed approach are particularly welcomed. Just draw out issues in relation to a couple of areas. Involvement on the Constitution highlighted the importance of the workforce and people agenda, and we heard the item earlier on the agenda around progress on our people plan. We're still working through the most appropriate form of governance for this. We're seeking to design arrangements that build on the success of our current people board, ensuring effective oversight of the workforce agenda and transparency while avoiding duplication of current arrangements. And finally, the health transformation work at West Yorkshire level around service design, clinical pathways and clinical standards has until now been overseen by our Joint Committee of Clinical Commissioning Groups. The main options for the future governance around these functions are to either reserve the functions direct to the ICB board or establish a West Yorkshire level transformation committee to take on those functions. Again, views on any aspect of the handbook are welcome, but particularly on the committee membership and structure issues that I've highlighted under the key issues. So that was all I was planning to say, Chair. Happy to take comments and questions.
Thanks, Stephen. Thanks for taking us through what's, as you said, quite an important and detailed set of documents. So, any questions or comments from anybody on this? A lot of it is, as you say, capturing discussions we've previously had very effectively, I think. Yeah, Fatima. Yeah.
Thank you, Chair. So from a Race Equality Network perspective, we are absolutely really grateful for the opportunity to shape a number of the governance related conversations. So there's representation on the working group, as well as a number of other forums where discussions were taking place. And I think we're the first ICS, I can't find another one and I'm looking really hard, but we're the first ICB in the country that's got a Race Equality Network rep on their board. So I think the aspiration to ensure that we've got representation in all our decision-making forums is continuing strong. I suppose the only element of constructive feedback from the network was, are we being as ambitious as we could be? We are a very brave partnership when it comes to the way in which we operate. And is there further we could go to ensure that particularly the structures beneath the board within our places are as reflective as they could be in our aspiration to ensure that we've got the right representation in those forums. One of the things that we're doing in response to that as a network is reconfiguring our operating model to ensure that we're in a position to support places during that process. So it's just to sort of feed that back to the board, but to also say we are working on a resolution as well.
Thanks, Fatima. Kathy.
Thank you. I suppose I'm going to say something quite obvious. We're a very well established partnership and integrated care system. And so what we're doing is building on the good practice that we already have in place. And I've been talking to my colleagues across the country who are first of all trying to work out what their integrated partnership board will look like alongside their ICB, their integrated care board. So I suppose, Tim, there's something you and I have talked about for a number of months now, is how do we make sure these two entities work together? We truly deliver strategy at this level, in this forum. And Rob talked earlier about how we make sure the delivery on a variety of priorities, including community services and children's services, is overseen by the ICB. So Rob, I don't know and Ian, if you want to share your thoughts, but there is something about pausing for thought, because we're in a rare situation, a fortunate situation, where we have a very well established partnership. This is our 13th meeting. So how does it cross-reference and me taking on a role in working with you, Tim, in this forum, and you being an observer and connected to our integrated care board, how do we avoid duplication? How do we truly keep this forum strategic, our other forums around delivery, and we don't waste people's time? Everyone feels that they're coming to the right forum for the right purpose, and we're having effective, productive discussions and getting things done. So speaking quite plainly. So I wonder if we've got the September and the December partnership board meetings, and whether we use some time, perhaps this is my own personal suggestion, some time to actually just have informal discussions and working that out together, and as well as formal discussions. And I think Rob's report today is an example of how he's reported to the ICB in shadow form in detail, and today he's bringing the summary of that, and how do we make that effective in future. So, and Tim, I don't know what your thoughts are as well.
Yeah, no, that's interesting. Yeah, interesting point of view, and perhaps we could sort of follow up a discussion with people outside this meeting about whether we have an informal session, as you said. I mean, going back to before we established the partnership board, we used some development sessions to shape it, and perhaps it would be a good idea just to think about doing something like that to give ourselves a bit of space to rethink it. Interestingly enough, I'm jointly chairing what's the first meeting of a support group for integrated care partnership chairs tomorrow, which should be fascinating, really, because they're just in so many different stages of development. So go to Ian and then Rob.
Yeah, thanks, Councillor Swift, and thanks, Kathy. So three quick reflections on that. Firstly, I think having some time out in private to talk about the next steps and how we want to work is a really good idea. It's quite interesting. I think this is one of the few bits of our infrastructure that doesn't meet privately to do that development stuff. That's a really good suggestion. I think as part of that, and we've discussed this, Kathy, in the context of the ICB, having a bit of a clearer forward plan for both the ICP and the ICB, which gives people sort of clarity and certainty around future agendas and how they interconnect, I think would be a helpful thing for everyone. And then the third thing, and it's come up quite a lot today, but getting the data right and getting the data flows between the partnership board and the ICB, so that we know when things are going off track, and so we have that intelligence sort of backing up our conversations, is something that we need to prioritise as well. So I'm supportive of the principle of what you suggested, and a couple of things that might help.
Thanks, Ian. Rob?
You're still on mute, Rob.
There you go. I've ruined it for everybody. I thought we were going to get through the whole meeting without anybody being on mute, but never mind. So I think the crux, this is the key question for all of us, is how do we maintain our principle, our founding principle of subsidiarity being applied here? And what we want is, this partnership board set the strategy and have oversight of its delivery, for that to be delivered through the Integrated Care Board and its partners. But the Integrated Care Board and its partners, really, most things get done at place level. And that means the place committees and the health and wellbeing boards need to have a good relationship, and they need to have the capacity to deliver. And the places need to report to the Integrated Care Board about how they're getting on, and really escalate things on the basis of risk in a culture which is very open and honest, because that's what's done us well so far. That's why we've been able to manage our money better, our risks better, our development better, and get to this stage of maturity, I think. And not better than others necessarily, but better than previously, I would say. So I think that we need to do some OD work if we're going to, retain that spirit of openness and transparency, understand the way that we manage and organise risk and tolerate risk and set risk appetite, and have really effective working at system level, at place level, and in provider collaboratives. The alternative is, I think we'll potentially get snagged on our previous experience, and we'll try and create something that looks a bit like a trust board for the ICB, and we'll try and create this into some kind of non-exec holding to account vehicle. We don't want that, do we? This is new and different. So my personal view is that we're doing two things in this conversation. We're recognising that we need to do some OD work, and a bit of time out for this partnership would be good. And secondly, we're reinforcing, it's in the governance handbook, it's in the constitution, the importance and power of the places, which requires the Health and Wellbeing Board chairs, the council leads in those places, the place leaders from the ICB to feel confident that they've got the capacity they need to accept the responsibility and manage the risk. So I guess that's where we are with all of this. So I very much support all the papers, support the constitution, support the approach. I think we need some more D work.
Thank you, Rob. Kathy, you want to come back?
Thank you. And again, I'd say thank you to Stephen and so many governance colleagues who've worked on this, and for those of you and members of the public who've fed back on the documentation. It's great, and it's brilliant to receive a letter from our regional director saying that they accept our constitution and thank our governance colleagues for their work. So I want to say that one bit, Tim. I think there's something in the context of the public question we had this morning, which was veering into sort of political questions around how do we lobby government, for example, and in some ways that's not the role of the Integrated Care Board, but when do we have those discussions about the cost of living crisis and our response together as a partnership? And I think there's also then, which has been touched on today, a number of different national reports, and where and when do we respond to them, and the recommendations, the fuller report, but also white papers that are coming through. So I'd really love to just explore that together in where we want to respond and how we respond together, and who's best placed to do that best on networks, expertise and job descriptions, really. So thank you for those responses. I think that's really helpful in how we work together into the autumn.
Thank you. Yes, I agree. Okay, so we're very happy with the governance documents. Ian, you want to come back?
Yeah, I mean, just in relation to the specific questions that Stephen posed around a people board as opposed to a people committee, and having a transformation committee that does the work that the Joint Committee of CCGs previously did, rather than it being reserved to the board. I mean, I think we should go with that and test it as we go along. I think I think we had a conversation in the Joint Committee this morning around the work that we still need to do around harmonising of commissioning policies and prescribing policies. I think that would be a reasonable place to take that work. And I think, you know, having a people board rather than a committee of the ICB reflects that this will, you know, remain quite a broad partnership endeavour. So it seems to be the right approach to me.
Thank you. Yeah. Yes, I'd agree. I don't see others. Okay. Are there any more comments on this item? So can I just echo Kathy's thanks to you, Stephen, and to all the colleagues who've worked on these governance documents. And it's been a huge endeavour, and warmly endorse the work that's been done. So thank you. And I think that brings us to the end of the meeting, unless anybody has any other business they want to raise. Okay, well, thank you very much, everyone, for your time and your contributions this afternoon. And thank you to everybody who's worked on the papers and preparations for the meeting. And we can pick up in discussions outside how best to accommodate that suggestion around a development session. Thank you, and enjoy the rest of your days.
Thanks, everyone.